Good morning. Good morning. Hey, good morning, y'all. Good morning, everyone. Thank you for being here. My name is Ashley Wilson. I am a program manager in the Office for Health Equity and Inclusion, and I am so glad to see you all here this morning. So thank you for joining us at the Beyond Awareness Structural Change for Equity Fall Symposium. We have over 400 folks attending in person and also on the live stream. So please give yourselves a round of applause for being here this Friday morning. Before we begin, I would like to give a special thank you to some core folks who helped to put this symposium together. Myself, along with Sue Schreck, who is out in the hallway, also Brandon Bayer, also Dan Russell for the amazing setup that you all see here today, Nathan Hankey, and also all of the Office for Health Equity and Inclusion staff. Thank you all so much for your help in organizing this great event. Next, I would like to introduce Dr. David Brown, the Associate Vice President and Associate Dean for Health Equity and Inclusion, who will bring opening remarks. Dr. Brown.
Good morning, everyone. Thank you, Ashley. I first want to thank Ashley Wilson because this was her baby, and she did an incredible job. So I want to give her a round of, she didn't give herself a round of applause, so let's give it for her. So I'm David Brown, and I have the honor to serve as the Associate President and Associate Dean for Health Equity and Inclusion and Professor of Otolaryngology-Head and Neck Surgery. It's my pleasure to welcome you in person and virtually, and some of the in-person individuals are in our overflow room, so I'm really thrilled that so many people wanted to come to this event that we needed extra space. Today, our symposium is entitled Beyond Awareness, Structural Change for Equity. There are so many people, as Ashley said, in M.H.A. and others who worked extremely hard in planning this amazing kickoff to our DEI 2.0 strategic plan, which is going to be from 2023 to 2028, as well as provide community that we're all here today and transparency about what we're doing and the opportunities moving forward. I'm also appreciative of all those present here today in person and online, and the audience. Our audience is virtually and in person, the panelists, the presenters, and the leaders who are here. Each of you represent our commitment to diversity, equity, and inclusion, and health equity, so thank you. Today is structured to inform you how we're implementing our, what I call alignment over addition, by aligning our DEI 2.0 strategic plan with our health equity goals. We know that everyone is busy and doing a lot of great work, and if we can align that, that will help us achieve our goals better. As we transition from DEI 1.0 to 2.0, I reflect on our journey up to now. I'm grateful to all of you who helped Michigan Medicine reach thousands and thousands of DEI achievements, including new and inclusive programs, policies, practices, and professional development opportunities. Thank you to the DEI leads, the DEI drivers, DEI associate chairs, and all the faculty, staff, and learners who helped us achieve so much. Let's give a round of applause for all of those individuals. I'm so proud and appreciative of all the work that we collectively have done, yet there's still much more to do. I'm also reminded of the local, national, and international tragedies and crises that our diverse community came together to support each other. These include our national reckoning with racism, COVID-19, and the healthcare disparities that the pandemic highlighted. This brings us to present time in the last 2 weeks. We unequivocally denounce the recent terrorist actions perpetrated by Hamas. The fighting, bloodshed, and human displacements in Gaza and in Israel are bringing pain and grief to those in the Middle East and in our community here at Michigan Medicine. Additionally, the national and international rise in anti-Semitism and Islamophobia exacerbates the fears of personal and psychological safety amongst our local Jewish and Palestinian communities. We stand against all forms of hate. I expect that our Michigan Medicine community will live our values of diversity, equity, inclusion, and caring by engaging our Palestinian and Jewish faculty, staff, learners, and patients impacted by these horrific events with compassion, dignity, and respect. Can you put on the next slide? Or I do it. So your safety and well-being are paramount, and I encourage anyone in need of these safety and well-being resources on this slide and in the QR code to utilize them. Let's hope for peace and humanity globally and locally. Thank you. Now I'd like to introduce Dr. Katrina Wade-Golden, the University of Michigan Deputy Chief Diversity Officer and Director of Implementation for Diversity, Equity, and Inclusion, our Diversity, Equity, and Inclusion Strategic Plan. She will bring us greetings from the Office of Diversity, Equity, and Inclusion. Welcome, Katrina.
Thank you so much, Dr. Brown, and good morning, everyone. I am truly honored to be here today and along with Dr. Brown to welcome you into this space of community. And even as we think about the myriad challenges that we face on this campus and in society generally, as Dr. Brown was referencing, this is an exciting time for the University of Michigan as we launch our DEI 2.0 plan. It has been a lot of hard work, and we are so grateful and appreciative for the support and the partnership that has been afforded to us centrally by Michigan Medicine. This work could not be accomplished without you and the many teams and of folks and those who benefit from your services have weighed in to constructing the type of plan that will be impactful for Michigan Medicine and beyond. As I reflect on our work, as I said, it's been hard work over the first 5 years of DEI 1.0 as we engage our respective communities, but we were really intentional about carving out the space for evaluating what happened in DEI 1.0. So we spent an entire year to really assess what went on in Michigan Medicine as well as across campus as it relates to the accomplishment of our DEI 1.0 goals. We then spent an entire year involved in the development of our DEI 2.0 plans. So this is 2 years in the making, but we're here. We're launching DEI 2.0, and it really is a manifestation of our continued commitment to engaging the work of making our campus community more diverse, equitable, and inclusive for all. So I invite you to read the DEI 2.0 plan. So you can find it at report.dei.umich.edu and learn more about the actions that we're taking up centrally and also the actions specifically that Michigan Medicine is taking up. I understand we'll learn a little bit more about that this morning, but I do want you to get a broader context of the work that we're lifting up across the entire campus in relation to our DEI efforts. The way in which we engage our DEI work is really unique in higher education because we are simultaneously activating a distributive and a centralized planning process. And what I mean by that is, while most universities develop a centralized DEI plan, and usually it's a small collection of individuals who come together and develop it and then roll it out for the entire campus, we were really intentional about bringing folks and units together to really think about what made sense in their respective places. So to have these plans be localized and to speak to the unique needs and priorities and gaps within the respective units. So again, doing both things, developing the centralized plan to be able to support what's happening all across campus, honoring the decentralized nature and structure of U of M, and also developing 51 unique plans, 51 plans, if you can believe that. And I spent my entire summer, along with our team, reviewing all those plans. But really impressive plans, and they encompass all of our schools and colleges, the athletics complex, the Michigan Medicine complex, and all major administrative units on campus. One of the critical elements, and laid out on this graphic here, some of the critical cornerstones are engagement and evaluation. We're really intentional about making sure that individuals within our units lend their voice and their perspective to what they want to see as priority areas for these plans. So engagement is key. We also are intentional about evaluation. So assessing our progress year over year as we move forward. We think about these plans as living documents. So they should be evolving. So we should be building, growing, and evolving these plans year over year as we get new information from our community. That's why it's so important for gatherings like this to have you present, to be able to hear about the plan so that you have an informed way forward as it relates to identifying successes, challenge areas, gaps, and opportunities. And the other thing is that our DEI 2.0 plan builds on the successes of DEI 1.0, but not just the successes. We wanted to learn about what were things we should sunset. You know, what were new priority areas? What were new gaps that we needed to advance forward, or to address, I should say. And so we really took all that information from our collective communities to move forward and develop the DEI 2.0 plan. All 51 plans at the university had to address 3 objectives, and we call them our 3 Ps, or people, process, and products. What we mean by people is that we ask units to specifically name and call out strategic objectives and action items that are centered on recruiting, retaining, and developing our community. So really increasing the diversity of that community and then supporting those individuals. Process is in relation to creating inclusive and equitable policies, practices, and procedures, and also engaging in actions that undergird an inclusive and equitable campus climate. And then our products are in relation to supporting innovative and inclusive teaching, scholarship and research, and service. So all 51 plans needed to respond to those 3 Ps. What's represented here is our DEI in 2.0 action model. And what we developed was a centralized plan that had 20 campus-wide action items that, again, have been developed in partnership with units like Michigan Medicine. And I talked about the 51 individual unit plans. But the key thing I want to point out in this graphic is that we don't do this work centrally, or we don't do this work alone. In addition to partners like Michigan Medicine, there are a variety of foundational programs on campus that we draw on for support as we advance this work forward. So some of the units include like our National Center for Institutional Diversity, our Advanced Department, and our Organizational Learning Department, which is responsible for developing tailored learning experiences in relation to DEI. And lastly, I just wanted to present to you our theory of change, or our institutional change model, because I want you to know that this work is taking place in a very intentional and structured way. And fundamentally, the plan is really designed and developed to shift the culture at the university in relation to diversity, equity, and inclusion. And all of these, or all 5 of these elements, are fundamental for achieving the cultural transformation that we see. So starting at the bottom, the model begins with raising institutional awareness. And we did a lot of work in 1.0 of level setting and creating a baseline of understanding in relation to those concepts, diversity, equity, and inclusion. And I really love the title of the symposium today, Beyond Awareness, or because it really signals that while that is important, we certainly cannot stop there. So beyond awareness. And so we start there, and then we focus on enhancing individual skills and capacities in relation to diversity, equity, and inclusion. So that's where these learning and development and training opportunities become critically important, ensuring that we have the requisite skill and familiarity with engaging difference in our respective places. But we can't stop at just the individual level. While that is important, we need to focus on aligning our policies, our practices, and our procedures so that DEI becomes a critical component of those processes as well. And sustained engagement in this process then creates cultural norms and reinforcers that contribute to the goal of broad institutional access. And when we talk about institutional access, we're doing so in a broad way. So, everything from leadership development opportunities, how are we in building out support programs for underrepresented individuals in our spaces, and creating environments and contexts where everybody at our campus can learn, grow, thrive, and excel. And so again, we appreciate the partnership of Michigan Medicine as we lift this work up across campus, and I wish you a very engaging session today, and I hope that you learn a lot. And remember, be in community, learn someone or meet someone that you don't know, and capitalize on that. And thank you for moving forward in this work together.
This isn't a part of my script, but I just recognize that I have one of my sorors who just presented in front of me, and then I will be inviting another one. And so thank you to the lovely women of Alpha Kappa Alpha Sorority Incorporated. Not a part of my script, but I just had to acknowledge that. Thank you, Dr. Wade Golden, for those wonderful remarks. Next, I would like to invite Kristen Howard, who is the director for the office, the senior director for the Office for Health Equity and Inclusion. She will come and provide an overview of the DEI 2.0 plan for Michigan Medicine and really set the foundation for today's events. Kristen?
Good morning, good morning. So this is really an exciting time when we get to talk a little bit more about the work that many of you already have had an opportunity to be a part of. And so I think of this as a little bit more of a direct welcome to our journey in DEI 2.0 here at Michigan Medicine. As Dr. Wade Golden shared, we are part of a larger context, and I really appreciate her walking us through how all of the things that we are doing here roll up and become a part of what the university as a whole is doing. There's a real opportunity, I think, that we are working to take advantage of to partner with other units, not just in Michigan Medicine, to help us effectuate our goals in DEI, even within Michigan Medicine. And so as was shared, there have been several phases of this DEI journey at the University of Michigan. And so the first 5 years, as many of you know, but for some this will be your first time, the first 5 years of DEI strategic planning really as a university priority began in 2016. And so from 2016 to 2021, the first 5 years of DEI strategic planning occurred. And so there was a lot of effort and energy each year into evaluating and thinking about what we were doing at Michigan Medicine in order to meet these university-wide goals. I joined Michigan Medicine actually in 2021, and at that time we were they had just finished the final academic year of the DEI 1.0 plan. And we began a really robust evaluation process. About 60 different departments within Michigan Medicine alone participated in evaluating activities that went on to support diversity, equity, and inclusion within our space at Michigan Medicine. And so we got an idea of what went on supporting those people, process, and products objectives, and how we could do more moving into DEI 2.0. So we moved from that evaluation year into our DEI 2.0 planning, which began in late 22 and occurred even on into this year. And so we have been engaging with stakeholders across Michigan Medicine in order to arrive at our DEI 2.0 plan. And today we are here for the launch of DEI 2.0. And so a question that I kind of hear sometimes, and I think is worth asking, is did our focus on DEI and health equity stop during the planning and evaluation stage? Because there wasn't as much conversation. For my DEI leads in the room, we met a little bit less often and came together as we were thinking things through. But I want to, resoundingly answer, no, the work doesn't stop as we plan and evaluate. And I want to highlight some of the really amazing initiatives that we've been able to accomplish at Michigan Medicine over those planning years. And so I'll start with kind of a big one that many of you have likely participated in, but may not know the full story, our Building Toward Belonging implicit bias training. It started off meeting a licensing and regulatory affairs goal of ensuring that our licensed healthcare professionals had implicit bias training. And so our first year was synchronous, meaning live facilitators had to come together and meet with all of you in order to deliver this training. But what some people might not realize is that it wasn't just a singular department or unit that made this possible. Operationally, our adult hospitals team led in ensuring that there was time and space for everyone to access this training. Our quality department's project management office offered up support in forming our original facilitator schedule and beginning this synchronous activity. And then our medical group, DEI leaders, both Andrew Hickok and Steve Vinson, really took on an additional role in ensuring that all of our ambulatory clinics had access to this information and became certified trainers to deliver this content and make sure that there was access for our ambulatory leaders. We learned eventually that the state had changed their requirements from synchronous to asynchronous, and so we were able to pivot relatively quickly to an asynchronous offering. And we also realized in hearing from all of you that it didn't always make sense for everyone to take a full hour because we have very different jobs. One thing that makes Michigan Medicine unique within the university is this focus on patient care. We have a duty, many of our teams are not able to sit at a computer for most of the day. They are in active patient care. I think even when we're in a room today that we have to think about those who can't join us because they're in patient transport, because they're nursing, because they're doctoring and surgery calls started at 7 a.m. There's a lot going on within Michigan Medicine that doesn't always lend itself to this format of these times when we come together and are able to reflect and think. So we're grateful for all of those professionals, and we want to be thoughtful about how best to serve them. And so our Michigan Medicine Human Resources team stepped up to the plate, and the institutional mandatory mandatory education and design team, which everyone's like, is there an institutional mandatory education and design team? Yes, in fact, there is. And if 80% of us need to take a training, they do an amazing job of creating interactive content that we can access online. And they were great partners who really actually cared not just about doing this because it was a mandatory, but about DEI and delivering a great product for the culture of our institution. And so from that work, in our first year, 29,000 of our Michigan Medicine colleagues, faculty, staff, students, residents, and fellows joined together and participated in over 500 live sessions in addition to our asynchronous sessions in participating in this event. And it carried over into a second year. And so in our second year, we have made an intentional focus around our LGBTQ+ population to think about how do we go deeper in where our biases show up. We all have implicit biases, as I think we hopefully have learned with those 29,000 of us who have taken this training so far. And so they show up in different ways as we address different communities. And so we're deepening our learning while still appreciating the requirements of the state. And so again, that Michigan Medicine Human Resources team joined with us. Our LGBTQ+ Health Advisory Committee did a wonderful job of joining together to help review content and ensure that what we were doing was responsive to our needs as a community. And then, of course, our communications team had to step up and make sure to get the word out. And so when we think about what makes DEI work, it's not that everyone suddenly becomes a DEI expert and does the work that we do in the Office for Health Equity and Inclusion, or that they do in O-Day on campus. It's that everyone in their unique roles and positions throughout the academic medical center steps up in their areas of control and focus and comes together to make great products and to make great opportunities for all of our faculty, staff, and learners. And so far in just 3 months, based on the work that all of us have joined together and done, over 13,000 people have participated in year 2 of this training experience. And so it really shows that there's a commitment among our colleagues to being willing to learn, to stepping up and getting it done. And so we're really excited about what has been able to be accomplished in the training realm. And so another fun area that a lot of us have got to participate in at Michigan Medicine is the Youth Summit at the Big House. Many may not know the history of the Youth Summit. It started in 2022, and it actually started from an idea in the Department of Urology. And they wanted to bring an opportunity for students who might not otherwise have exposure to doctors and might not know a lot about specialties to interact with our diverse professionals in healthcare. And so we started meeting as a group, and we thought about partnering with other existing opportunities. And Dr. Brown said, you know what? Michigan Medicine is pretty great. We don't need a partner. We don't need anyone. We got this. And he was right. And so in year 1, we were able to come together with all of our unique departments. We were all a little nervous because not most of us don't work with middle schoolers on a regular basis. We were like, will they listen to us? Same thing for the Department of Urology. Can we show them an anatomically correct urological cycle? Those questions came up. And we were really excited about what has been able to happen from that start of just figuring it out. We've been able to serve over 600 middle school students. More than 25 of our departments over the 2 years have been able to serve, from revenue cycle, who made it rain year 1. That was the favorite game of the students, learning about revenue cycle, to dermatology, and of course, otolaryngology. Everyone showed up to make a unique experience for our students. There was over 500 faculty, house officers, fellows, nurses, and professional staff who made this event a success. And so this is another shining example of how we come together as a team at Michigan Medicine, not just to impact our patients, but also to step out and touch our community. And so we're really excited for year 3. We have additional partners. We learned our lesson at the end of year 2. We actually have to cap enrollment for students now, because we started getting outreach the day after the Youth Summit ended to ask to reserve spots for 2024's event. And so we're really excited to do this again and keep that connection to community. Another really amazing event that happened at Michigan Medicine over these last 2 years was just in 2023, the first annual Health Equity Month. That was led by our Associate Chief Clinical Officer for Health Equity, just bringing everyone together. So there were over 30 sessions that occurred in April 2023 across Michigan Medicine, bringing together over 1,200 attendees just to talk about how we can do better in our clinical research and community engagement areas around health equity. And I know that we're excited to see that Health Equity Month returning in April of 2024. I think there will be announcements soon about how to register events. And so we're really excited to see all the places and spaces across Michigan Medicine where the work continues. And then finally, we had our first annual, and I don't know if we've called it first annual yet, but I'm calling it the first annual because it will return Pride Month celebration for Michigan Medicine. And so there was really a weekend of activities and events that was led by our LGBTQ+ Health Advisory Committee that really gave us an opportunity to dig deep on the needs of that community and think about how we can serve. And there was hundreds of folks who were able to participate both in the research arm, in some really pointed meetings to talk about next steps and how we can establish better care, but also a better place for all of our faculty and staff who work and are a part of our community here. So as we reflect on DEI 1.0, think about the work that continued even in those gap years. We asked the question, what did we learn? And this is when we get to what Dr. Brown mentioned, our journey to alignment over addition. So during our strategic planning feedback process, where we were able to really engage with you all and understand what were the needs of our Michigan Medicine community, we talked to about 5,100 folks through our survey. We did a quick questionnaire. We got to hand out some snacks and accost people with a QR code and say, please just take our survey, please just take our survey. And then we held some live feedback sessions where we really got to talk with folks. And we did have 24 individual reviewers. So we took it really broad. We narrowed it down to folks who could come to in-person feedback sessions. And we were really intentional about that questionnaire because, again, not everyone can take that time away to sit down and come to a feedback session or do a focus group. So we wanted to have a way that everyone could engage. We then invited individual reviewers who have a more significant role in DEI work to take a look at our plan. We worked with about 17 audience experts. So whether if it was a teaching and learning goal, our faculty in the medical school were able to help us out. And so we went through and really carefully made sure our strategic objectives aligned to the work that was occurring and that could grow throughout Michigan Medicine. And then after our plan was submitted, we started just engaging with people around what was to come, getting people excited for today, planning for the symposium, and to date, about 500 folks have been engaged after the plan was submitted to share some of our big objectives going forward. And so what did those responses tell us? First, I think it's important to note that out of those 5,000 respondents, at least 10% of them were faculty, at least 10% were students, 10% of our staff, and 10% of our nurses. And some were overrepresented, but we made sure to go back actually and do additional rounds to make sure that we didn't miss the voice of some of our largest stakeholder groups. And so the top rated priorities, really when we just think about culture, community, inclusion, belonging, were how do we manage burnout and fatigue? That was the top priority both. We actually looked at our data by those who were patient-facing and those who worked in non-patient-facing roles. And in both areas, the number one concern was how do we manage burnout, workload, and fatigue. And then the second issue was how do we foster inclusive communications? How do we get people talking to each other in a way that's respectful? And then how do we equip managers and leaders to do this work? And finally, how do we transform systems? And so when we were thinking about how to approach this within a healthcare space, we kind of happened into two strategic planning frameworks. And so I like to highlight this because since our number one issue was managing burnout, we want to make sure that we find a way, if we have two different frameworks or two different sets of needs, that we're harmonizing them. And so on the one hand, we learned that DEI is not enough in the healthcare space. For us, we also are really focused on health equity, right? What does DEI look like in a patient care, in a hospital setting? What does health equity look like? But I think, and I know now because we've written this plan, that our overall DEI 2.0 plan from our university is broad enough to include even patient health equity. And so what we did was mix in a lot of elements from the American Hospital Association's Health Equity Roadmap. And so it's actually fully incorporated into our DEI 2.0 plan. So our DEI 2.0 plan really helps us to address that academic focus, the student side, having faculty, learners, which is not necessarily addressed by the AHA, but then the AHA really brings that focus to how are you addressing patient care, how are you looking at supplier diversity, the things that really come up in a hospital setting. And so our DEI 2.0 strategic plan requirements are aligned with our AHA Health Equity Roadmap structure. And so if you hear someone talking about the Health Equity Roadmap or about DEI 2.0, don't worry. We do not have two different DEI activities or initiatives going on. They have been harmonized and they really work together to ensure that we're meeting the needs of our full population here at Michigan Medicine. And so as Katrina shared a lot about how DEI 2.0 works and the larger framework, I'll dig in a little deeper on how the Health Equity Roadmap works. And so the AHA Health Equity Roadmap is centered around 6 levers of transformation. And the first is culturally appropriate patient care. How do we practice cultural humility and activities that improve our culturally appropriate care, such as language, access, and health literacy? And then it takes a look at equitable and inclusive organizational policies. And that's really applying a DEI lens to the way that we treat our employees, the way that we look at our policies and procedures, and our climate and culture work. Then there's collection and use of data to drive action, which is really important and aligned to our DEI 2.0 plan again, where we're really looking at how are we evaluating things. And so how do we use quantitative and qualitative data to inform and design improvement strategies? We're really excited. I'll take a pause in the middle there about what we're going to do today, because as you listen to the presentations today, and if you look into your program, they are aligned to the 6 levers that we're talking about today. So they will be aligned to these 6 levers of transformation on the Health Equity Roadmap. So the next lever is community collaboration for solutions. How are we engaging our unique community to be a part of this work? Diverse representation in leadership and governance. I really like this lever because it looks at our really senior leadership, our board leadership. How transparent are we? How are our leaders being engaged? How are we working to diversify our leadership opportunities? And then collection and use of data to drive action, which I went over. And finally, systemic and shared accountability. And that looks at how have we allowed this work to permeate our system. So our DEI leads, our employee resource groups, which at Michigan Medicine we call just resource groups because they're open also, of course, to our learners and to our faculty as well. And so we are looking at these 6 levers of transformation, and those are really serving as the centerpiece when we think about the needs of our hospital system. And so what the Health Equity Roadmap does is look at each of these levers along a continuum of change. And so the beginning of that continuum is really the exploring level. And when we're at exploring, it's the start. We're planning, we're thinking it through, we're writing things down, but that's just the beginning. We move on to committing. That's when we start to implement those plans and strategies that we've developed. From committing, we move to immersing. And this is a really important lever. After we've planned, we've thought it through, we've begun our steps, we're ensuring that leadership is accountable and aligned to the plans that have been made and that those are the plans that are moving forward. And then we begin to move into affirming or institutionalization. Once we've gotten to the point where we've got the plan, we've started to move, our leaders have affirmed the accountability structures, how does that flow out? How are we consistently implementing across the institution? How are our policies affected? And once we reach that institutional level of change, we're able to transform and move community. And what I really like about the continuum that they provide us in this assessment is that there's an expectation that each layer builds upon the next. We can't skip to changing our communities before we get our leaders on board. We can't skip to creating institutional policy before we have a clear plan and a clear system for how we'll move forward. And so what we've done is done a health equity transformation assessment, which looks at where we are on our 6 levers along this transformation assessment. And again, every step of this is not an oh-hey thing, and that's why I haven't said it at the Office of Health Equity and Inclusion did any of this. It is a group effort. There are so many people who have contributed to this. I think it was probably about 30 to 40 folks who had to fill out, provide data and information in order for us to complete the health equity transformation assessment. So this is representative of our work across the system. Now, this was our first time completing the assessment, and we were all kind of learning the system, so we're excited for our next round, but we did get our results back in the first round, and so we are, for culturally appropriate patient care, our designation was exploring. One interesting part about the designations is that each of these 6 levers, and feel free, I Google everything. If you Google M.H.A Health Equity Roadmap, there is an extensive, and we could also provide the website, but there is an extensive website where you can go really deep. We also have a knowledge page on the OHA internal intranet site that kind of breaks down each of these levers, but they have sub-levers. And so your score on any given lever is not just did you do something, it's have you moved each of the sub-levers too. So if some of your sub-levers are all the way at transforming because you've done a really great job on this piece of the work, if one of your levers is still at exploring, overall, you're still at exploring. And I think that's important because when we're working towards transformation, it doesn't happen when we just address one piece of the puzzle. We have to get to the place where we're working through things holistically and we're able to address that entire puzzle and it fits together. That's when we get to transformation. And so in collection and use of data to drive action, we also were at the exploring rate and then at community collaboration for solutions. And so we then got to committing for equitable and inclusive organizational policies. Again, that goes back to our HR work and our culture work, and then immersing for diverse representation in leadership and governance. And quite frankly, partially this is because we are a public university and we are very transparent as a part of being a public university. So that puts us ahead of some private institutions pretty quickly because we provide a lot of information as a public entity. And then again, in systemic and shared accountability, and I will give kudos again to our Office of Diversity, Equity, and Inclusion because that's where they talk about DEI leads and how much has DEI permeated your institution. And I think that that comes from DEI 1.0 and creating those structures for DEI leads that really allowed us to move forward in systemic and shared accountability. So it's a start, it's a baseline, but there is definitely work to be done. And so we are excited for what is to come. We are excited to hear today some of the unique work happening in each of these 6 levers. We are looking for opportunity to partner with each and every one of you as the work continues. So as you're listening today and learning about the things that are going on, I hope that you will listen with an ear towards engagement. How do I get involved? How can I support this initiative? What am I doing similarly in this area of work so that over lunch I can connect with these stakeholders and say, hey, we've been working on something similar. Is there a chance for us to partner? Is there a chance for us to align the great work that we're doing to be additive? When we think about this managing burnout, workload, and fatigue, there are some deeper levels that our wellness office, I know we have representation here, is working on. But one of the things is that we can't always add something new. We can't always throw a new activity, a new initiative at the project. Some of it comes to all of the amazing things that are already happening here, us working more closely together to support each other in that work, to create partnerships, and to deepen the work based on the resources and time we're already expending. And that's how we get towards alignment over addition. So as you listen today and you hear from our leaders, you hear from those who are doing the work every day, think about how you can support, how you can bring this home to your own unit, and how there can be opportunities for partnership. And at the end, I will come back and talk a little bit more about how the Office for Health Equity and Inclusion is going to be supportive in facilitating those connections and opportunities to bring that work together. So thank you so much, and I hope you enjoy your time here today.
Thank you, Kristen, for those remarks. So I am very excited to introduce the next portion of our symposium today. This next section is called Traveling the Health Equity Roadmap. So as Kristen Howard mentioned, of the 6 different levers, we're going to travel this roadmap to think about what is happening in each lever, what are some entities and ways that you all can collaborate. And so in the programs, there is a QR code that you all can scan or a link you can follow for all the bios of the presenters in order of appearance. And I would like to ask the Anti-Racism Oversight Committee to come to the stage first to present.
Good morning, everyone. My name is Maria Bobo, and I'm the Director of Nursing Professional Development and Education and over our Magnet Recognition Program. And I am one of the co-chairs for our Anti-Racism Oversight Committee.
Thanks, Maria. Hello, I'm Michelle Caird. I'm the chair of the Department of Orthopedic Surgery, and I have the pleasure of co-chairing the Anti-Racism Oversight Committee with Maria Bobo. We'd love to tell you a little bit about the work that's been done so far and where we're headed. And if we could have the slides up. Thank you. So just for a little bit of background, the Anti-Racism Oversight Committee was launched in July of 2020, following social unrest across the country. There were charges for the Anti-Racism Oversight Committee, and the initial charge was to identify practices that contribute to racism and discrimination and recommend changes in Michigan medicine. We also worked to identify an approach that achieves an anti-racist culture and to utilize dashboards to track progress. And then finally, to develop and recommend a plan around contributions we can and must make to eliminate racism and inequities that exist in our workplace. And this was the leadership statement supporting anti-racism. I'm not going to read it to you. But please note that at the highest levels of our institution, this change was endorsed and encouraged. So, just to highlight some of the many accomplishments of AROC 1.0, we were able to institute intentional recruitment strategies, mentoring, and career support. We initiated exit interviews with key workforce. We incorporated critical race theory, health justice, and intersectionality training into the longitudinal doctoring course in the medical school. And again, this was generated from the students saying, we need this, and I'm very proud that our institution responded so effectively and put resources toward it. We also standardized clinical calculators to help address bias, embedded right within our charting system. We wanted to make sure that we were charting correctly and being bias-free. We provided training materials for local leadership and wellness advocates to create psychological safe spaces, created Speak Up and Show Solidarity toolkits, and finally partnered with the Ypsilanti community to address health equity in our own county. As we completed some of our initiatives in AROC 1.0, we worked to create a strategic plan to go forward. And there were 4 planning sessions held, and we surveyed all the members of AROC. There were weekly conversations and 10 meetings, and 3 themes emerged from that work. They were connectivity, accountability, and advocacy.
Thank you, Michelle, for that great overview of AROC 1.0. So I'm going to share with you how we have moved into AROC 2.0. And I want to assure you that the leadership has changed, but our commitment is very strong. So we, Michelle and I, had the pleasure of being asked to serve as co-chairs of this incredible work and work that needs to be done. And just know that as leaders of this work, we are very committed in making sure that we align ourselves with AROC 1.0, but we're excited to get started with 2.0. So even though, again, we changed leadership, we continued on our mission, and we created a charge. And our charge is to oversee the implementation, development, and evolution of initiatives and identify some of those challenges, but also make sure our structures, the behaviors that could perpetuate systemic racism at Michigan Medicine, that we are actually making sure that we are removing those barriers, removing those challenges for all of you that work here. So we are committed to some of the following things. And I'm gonna put my glasses on, guys. I'm sorry. I'm so sorry. The font is just too small for me. I apologize. So, a couple things that we're committed to, and that didn't make it better. So, this is what happens when you get old. So we are forming interdisciplinary working teams, and we're gonna talk a little bit about that work shortly. We also want to be committed to communication, making sure we are holding true to the expectations of everyone, our communities and our staff. Also, we want to make sure that our institution, thank you, is accountable for the keeping us on track, because we know we do great with implementation, but are we staying on track? Are we evaluating, and are we completing our tasks completely? And then we want to make sure you have all the resources that you need to do your job. So that is our new charge. So this wonderful visual structure will tell you how AROC 2.0 is set up. So you can see in the upper right, my right, you'll have our working group leads, and we will go through that shortly. But Michelle and I are in the green section, and we serve as the committee co-chairs. We also have program management support and administrative support. We have an executive sponsor, and I'll talk about that shortly. And in the middle, we have our Anti-Racism Oversight Committee. And that is a combination of many people who are dedicated to this work. And then finally, we'll talk about our public meetings. So we are so excited to have our executive sponsor, Quinta Reed, supporting us in this effort. She gives us guidance and support. She aligns us and makes sure we're aligned with our strategic plans. She helps us secure any resources and remove any barriers. And she is our spokesperson to talk to the executive team when we need advocacy on behalf of the Anti-Racism Committee. So thank you, Quinta. And then talking a little bit more about that oversight committee that we have. And the purpose, again, is to have a sounding board, to have a group of individuals who are dedicated to this mission and to our charge, to hold us accountable, make sure we're staying in alignment, again, with our strategic plan, support for those resources, have that group think, have some camaraderie, just making sure we're, again, in alignment with our DEI 2.0 and what our employees, our staff, our listeners, and faculties are needing to do in their job. So I want to show you this slide because you will see I'm going to let's go back, sorry. There we are. There we go. So I wanted to show you this slide because I wanted to show you who sits on the Oversight Committee. And it is a very diverse group of individuals from various entities of our institution. We have individuals who have been asked to support us in their roles, but we also have volunteers. And about 3 months ago, we asked for individuals to step up and say that they wanted to work with us on this committee. And we did get volunteers, and they are supporting the roles of House officer, student members, and staff members. And we meet quarterly, again, to make sure we're in alignment, to share information, get comments, and make sure we're working towards it together. In addition, our working group leads are part of this committee. I won't go in depth, but again, I just want to make sure you know me and Michelle. And I couldn't ask for a better partner in this work. We really work well together. We're really passionate about this work. We're really committed and dedicated. And so we ask if you have any questions, concerns, you want to give us feedback, you have recommendation, please approach us. We'll be here today, as well as reach out to us via email. So the exciting part is our working groups. This is where the work happens. This is where all of the initiatives and everything that you have told us, this is where it comes to fruition. We have some wonderful working group leaders. Michelle's going to share who those individuals are and what they're currently working on. But again, they're tasked with those initiatives. There are committee members. Some of you in here may be part of those committees now. But this is where we are going to see things start moving and shaking and really putting the pieces together. So I'm going to turn it back to Michelle.
Great, thank you. So we are now in 4 working groups, and the first is Diversify the Workforce. Paul Sturgis and Susan Wolford are our work group leads, and the job there that they're working on is to diversify the workforce, oversee, support development and implementation of institutional initiatives. And there are 2 initiatives that they have selected to go forward. First, they're working to standardize, align, and integrate hiring guidelines across Michigan Medicine, and they're also working on a project to implement term limits for chairs, co-chairs, and members of committees to increase availability of leadership positions across Michigan Medicine in its many structures, and with the goal of including more people in these leadership processes. Our next group is the Education and Clinical Practice Group, and Carrie Grobe and Marcia Perry are our co-leads, and their work really spans a great deal of the work at the medical school. And they have chosen these 2 initiatives to get started. The first is work with the Health Equity Quality Scholars Program, which is a longitudinal healthcare disparities curriculum. And they are also working to create a repository of resources for existing work across all segments of education. Again, working for alignment rather than additive work. Our advocacy and engagement group is led by Sally Liao and Cassie Turner. I saw Cassie. And their work is to create intentional spaces and opportunities for conversation, as well as to communicate out the work that's being done. Here are 2 of their initiatives. To socialize that advocacy toolkit that has been created for managers, really for the speak up and show solidarity work, and also to create structure and processes to expand our community-wide talking circles. Finally, our last working group is community work, led by Alfreda Rooks and Ebony Parker Featherstone, and they get 15 more minutes after us to tell you all about their work. So I'll hold that. I'll turn it over to Maria.
Thank you, Michelle. So does that work sound exciting to you? Okay, wonderful, great. So we need you. This is not work we can do by ourselves. And we are excited to have our inaugural, that's a word, our first community forum. And it's gonna be November 9th. And we want everyone to get on this virtual platform with us. We want to listen to your voices. We're gonna go more in depth in our initiatives. We're gonna talk about some of our highlights, and then we're gonna talk about future things that we are looking forward to accomplishing together. So if you can save the date, we will send out an announcement, I believe, probably later this week for our first community forum. And we will continue to have these periodically so you can communicate with us. We thought it was an important feature of AROC 2.0 to have outreach, meaning reaching out and having opportunities for you to have conversations with us. So again, we want to invite you to that. But we also want to make sure we're aligning with anything you're working on. So if there's something you heard today to say, we're doing something in our department or similar, can we have a discussion? Because we definitely don't want to replicate any work. We want to work together. We want to be collaborative. And so if you see any alignment or something that interests you, please reach out to us. We've provided our email address here. So if you want to write that down or take this. I'm sure we can get that out to you after this presentation. But Michelle and I are so excited to be part of AROC and co-leads, but we need all of you to partner with us. And so we thank you for listening to our presentation. And I know we have our next speaker up, which we're excited to introduce because she is one of our working group leaders. So next we'll have our Frida Rooks come to the podium. And Susan.
So good morning. They fed you. You've heard some really exciting conversation, and I get good morning. Good morning, good people. Good morning. Thank you. As Maria said, my name is Alfreda Rooks, and I'm the Director of Community Health Services for U of M Health, Michigan Medicine. This is not Ebony Parker Featherstone. Dr. Featherstone sends her regrets and apologies. She is not able to be with us today. But Susan Wyman, who has worked also with these projects, is going to be here in her stead. And so, Susan, you're up first.
All right. Thank you, Alfreda. Yeah, clearly I'm not Dr. Parker Featherstone, but she's entrusted me to speak to her slides today, and I'm honored to do so. So I'm going to do my best. And it is usually my style to pace and point, but I'm going to try and stay tethered to the microphone so you can all hear me. All right. All right, so today I want to talk to you a little bit about the Ypsilanti Health Center Revitalization Project. So we have a picture of our current Ypsilanti Health Center on this slide. You can see that health center currently serves the cities of Ypsilanti, the neighborhoods of Willis, Whitaker, Willow Run, and then also some Belleville zip codes. And the impetus for this project was two things. One, when we looked at the data, we saw that our Ypsilanti neighborhoods had the highest rate of screening positive for the social determinants of health, and also the lease on our current clinic was going to be up in August of 2025. So we had to do some work around looking at whether we wanted to stay in its current location, which is the leased building in a neighborhood in Ypsilanti, or if we wanted to move to a new location. And so you can see here that was kind of our problem and opportunity statement. And then we developed a vision with a number of stakeholders of what we wanted that health center to look like. And so our vision for it is to become a premier healthcare provider in the Ypsilanti community, delivering equitable, interdisciplinary care for the whole patient, reducing health disparities, improving health justice, and utilizing resources efficiently while furthering our research and education missions. And then we developed the guiding principles that you can see on the screen. And so I'm not going to read them to you because we have a lot of material, but there's some, every part of this project we aligned with those guiding principles. All right, so a little bit of background on that health center. As I mentioned, it's located in a neighborhood in Ypsilanti. It is predominantly primary care, but it also has some embedded specialties, as you can see. And then we have some ancillary services. We have a lab, we have a food pantry, which is quite popular with our patients. And then we have nutrition, pharmacy, services, and then there is a non-affiliated pharmacy in that building. When we looked at the building, we noticed a couple things about it. One, it's not located on any public transportation route. It's not easy to get to. It's not very visible from the road. And there was no room for us to expand to add more services. And in community conversations, we knew that our patients wanted us to add services. Clearly, when you decide to move a practice, you have the risk of disrupting current kind of your patient populations, who you're going to serve. And so we wanted to make sure we were continuing to serve the neighborhoods and the populations that we did. And one of the things that makes the Ypsilanti Health Center unique is it's our most racially diverse practice across Michigan medicine. And so you can see on these slides, the one on the right shows the racial makeup of the Ypsilanti Health Center at the top. So that green bar is the patients who identify as Black or African American. The next row is Michigan medicine patients overall. So you can see there's a lot more, many more, that practice has a much greater population of Black and African American patients than Michigan medicine has overall. And in fact, even the people who live in Ypsilanti in general, which is that third row. And we saw this as a real positive, and we wanted to make sure we maintained that even when we moved. And so we've been very deliberate in making sure that the new center was located in a spot that would be convenient to those same patients. The other thing that was really important about that is this center is going to double in size, and so we'll be hiring a lot of new staff, we'll be recruiting new faculty, and we want to make sure that those staff and faculty represent the diversity of the patient population. We did some focus groups with patients, and one of the reasons we asked them why you chose the Ypsilanti Health Center for your care or why you don't. And the number one reason people say they did choose it for their care was the staff and faculty that looked like them. The two reasons people didn't choose it for their care was, one, they didn't know we had a clinic in Ypsilanti, and the second was there was the perception that it didn't have the services they needed. And then I will say this other chart just shows the age makeup. So one of the things we noticed about Ypsilanti is that it has a much smaller portion of patients who are 65 plus. And one of the reasons for that is just the mix of services in the building. So there's large peds practice, which is why you see a lot of pediatric patients. But it's also a clinic that is a little bit hard to access if you are mobility challenged. And so as people get older, it was a harder place to visit. And so in the new space, we are trying to work to make sure we're adequately providing services and meeting the needs of that 65 plus population. All right, why does this matter? Why is healthcare important to folks? I'm sure this is a slide that shows data that's not surprising to anybody, but it should be disturbing, it should be shocking, is that the key indicators of the health disparities within our county. So where you live in this county almost dictates your average life expectancy. You can see here some stats around infant mortality rate. The county overall is at 5.2 per thousand. In Ypsilanti Township, it's 9. The graduation rate between the Ann Arbor Public Schools, the Ypsilanti Community Schools, and then the life expectancy if you live in Ann Arbor versus if you live in Ypsilanti. So this is something that we want to work on improving. So it's been somewhat of a long journey, although it feels like it's gone pretty quickly. In the winter of 2020-21, there was feedback that was collected from our community on our need to prioritize the Ypsilanti Health Center as a strategic initiative. It was the formation of AROC, which included Ypsilanti and its community subgroup as a priority for work. In the summer of 2021, we got a work group together that was made up of many different groups: the Office of Patient Experience, AROC, the medical group, Ypsilanti Leadership, Community Health, Primary Care, Strategy, many people, to bring together a large group of voices to develop those guiding principles, to talk about what the new center should look like, to think about what a location, where it should be. And we looked at tons of data. So you can see we looked at internal data, market data, disease prevalence, things like where do our patients who live in Ypsilanti go now? What was interesting is we found a lot of our Black patients are more likely to stay at the Ypsilanti Health Center. Our white patients are more likely to travel to East Ann Arbor or our Briarwood clinics. It was an interesting finding. We looked at who our competitors are, who our collaborators are, what other resources are in the community, where are we seeing maybe less visits than we should. That community has like a higher rate of cardiovascular disease, and yet we didn't see a lot of cardiology visits. So why is that? Are they going elsewhere, or are they not getting the care that they should be? Looking at all that data, we held many stakeholder interviews with our specialty providers, other folks. We conducted a survey of patients, both of the health center and patients of other health centers. And then in the summer of 22, we had convened a smaller working group that really got into the details. So what services, how many, what does it look like, what do we need? And then it was approved in the fall of 2022 that we have a new building that's underway at this time. And so right now we're working on kind of our operational committee, our facility design, construction, and then one of the things, while the facility layout is done, one of the things we're still working on is what does culturally appropriate care look like in that community. So we're not counting on ourselves to figure that out. We're trying to bring together a group of patients, community members, to really talk about what does it look like to have culturally appropriate care. So when we want our patients and our staff to feel safe, having a security guard at the door might make some people feel safe. It might make other people feel very unsafe. So instead of depending on ourselves, we want to reach out to the community and our patients to say, what does this look like? What can we do? All right, so our near-term strategic plan is this continued investment in primary care. In the meantime, until that building's done, we've added services. We've added cardiology, we've added dermatology, skin of color clinic, we've added Other different services, the mobile mammography van comes to Ypsilanti. That was a need that the community really expressed that they wanted. We've improved access to virtual care. We've had community listening sessions. And then I know Alfreda is going to talk a lot more about our healthcare anchor work and other things with the community. And then our long-term plan is that we're going to have this new building. To better address patient care needs, we're adding a lot of specialty services, more ancillary services, and then we're trying to increase our community partnership and engagement in a number of ways. So this is a picture of the new building. Some of you might recognize it as EMU's old College of Business. It's been purchased by a developer who is going to put in some STEM businesses. We are going to be leasing 3 floors of it. So the top 2 floors for clinics, the basement floor for radiology. You can see kind of the proposed services. We're much expanding, and those services were really developed based on all of this community and stakeholder development. And then we're going to be having a lot of radiology services, food pantry, and those others. So with that, I'm going to turn it over to Alfreda.
Thank you. So as Susan said, this has been a very exciting project, and at every step of the way, we've either talked to patients or we've talked to our community. And so when we talk about why we're doing this, it's really in order to build community trust. And we want to meet the community where they live, work, play, and pray. And being downtown in Ypsilanti is meets one of those goals. So I want to give you an idea. Our community health needs assessment and social determinants of health about how we really began to look at this work. And it was important for us that all of the activities that we do in community align with our internal goals and our mission and vision, as well as what we have for community health services, and now with the creation of the inaugural Senior Vice President and Chief Environmental, Social, and Governance Officer. All of those things have to align. And so we also wanted to make sure that we were doing work that addressed not just our community health needs assessment priorities, which are mental health and substance use disorder, obesity and related illnesses, and preconceptual and perinatal health to improve maternal health and decrease infant mortality. We also knew that we had to go higher and address it at a root cause. And so we decided on 3 social determinants of health that we were going to work for. And that is poverty, housing, homelessness, social isolation, and then our emerging one, which is incarceration, climate change, and medical debt. This is our strategy. I'm only going to talk about the red box, which is community and how we engage with community. And so one of the things that we did to build trust was that we had community presentations. We had a very wonderful and impactful listening session with some members of the African American Black community. We had meetings with our potential collaborators across all of those fields around that circle that I talked about. We also began to talk about what we were going to be doing in Ypsilanti, especially with the mobile mammography unit. We talked about that in March at a women's luncheon. We did a fibroid awareness event in July where we also garnered additional feedback from folks who attended that. And then most recently, talked with the Washtenaw County Democratic Black Caucus about our work and what we were doing. Again, sharing the message so that we're not the only ones who's talking about it, but everyone that we meet is going to be talking about it as well. Our community engagement, one of the things that we wanted to do was 2 things. One was to verify and validate with community what we were putting into the Ypsilanti Health Center. And the other was to see if there were other things that we were not thinking about, and also to talk about how this would tie into our healthcare anchor work, which I'll talk about in a moment. So we had 170 surveys that was conducted on one of the hottest days in June. At Juneteenth, I was, spray tanning and giving water to everybody to make sure the students didn't fall out. And they did a very good job of collecting what we did. We talked about specific health concerns, and what you see there are the health concerns that we got feedback from, which align with the services that we're adding to the new Ypsilanti Health Center. And then we talked about, we've been taking this back to the community, so we've had 2 so far. We have another one next week, and then we have a webinar that's soon to be determined, because every time we take this out, we get more information to feed our mission, our goals, and our opportunities to improve health. As Susan said, we are part of the Healthcare Anchor Network, and our work is called Building Bridges, Connecting Communities, the Ypsilanti Initiative. There are 3 that you see, but I'm only going to talk about what we're doing as it works with our inclusive local hiring piece. And so what we want to do is make sure that the people who are in the communities that we are serving, where we know there's significant disparity, that we are providing them opportunities to have a solid foundation for economic wealth. And then also, if we can do that, we'll have great community health as well. And so what we looked at for this data was how many people wanted to get a better job, was there training that was needed, and we didn't just limit it to our 4-year degrees. We talked about skilled trades, GEDs, everything, the thought. And we'll also be doing this in our community, but we'll also be upskilling our own employees so that they have an opportunity to have advanced careers. And so these are some of the questions that we asked. You can see them on the screen. Our next steps, we have a meeting with our collaborators pending for next month. We have Workforce Development Committee meeting to develop a recruitment criteria. We're going to continue Michigan Cares, which is a pilot program between our Healthcare Anchor Network and our Program for Multicultural Health, elevating our Empower You program into a pipeline program, starting with middle school. And we're going to partner with Washtenaw Community College for training, certificate, and degree programs. And so we thank you for your time.
Good morning, everyone. I'm M.H.A. I'm a faculty member, associate professor in obstetrics and gynecology here at Michigan Medicine, and then also the associate chief clinical officer for health equity. And I'm glad to have the opportunity to come and talk to you, and along with members of my team, about the collection and verification of real and SOGI data, and I'll get into that in just a moment. So some of you may be asking yourselves, what does real and SOGI data actually mean? For those of you outside of the healthcare setting specifically, real pertains to race, ethnicity, and language, and SOGI refers to sexual orientation and gender identity. And I'll get into why this is important for us today and how it relates to healthcare equity. So I'll talk about our health system priorities and the nature of the problem that we're facing here and the workflow design that we are working on with a group of individuals to implement at Michigan Medicine to support equitable and inclusive care for the patients we serve. So you all are familiar with this, highlighting the Michigan Medicine priorities and outcomes, and we know that the crux of it all stands on building our base, so promoting the idea of belonging, access, safety, and experience for our patients and our staff, and how that works with the overall mission and vision for the health system, ultimately advancing health and to serve Michigan and the world. So when we talk about quality of care, we know that the Institute of Medicine issued this report back in 2001 to focus and prioritize safe, effective, efficient, equitable, and patient-centered care. And that starts with the demographic variables that we use to identify who you are and how you show up in our health system. So again, going back to belonging, access, experience, and safety, and then we interpose that or cross that with the idea of providing patient-centered care. And we really do have to think about someone's demographic variables. I know sometimes we get into this idea that we need to go beyond what someone may look like and how they show up, but that really does affect how they present for care, experience health care, and ultimately how we have to consider what we offer them. So that gets to the importance of why collecting and verifying race, ethnicity, language preferences, as well as sexual orientation and gender identity are important in healthcare delivery. So looking at our own institutional data at Michigan Medicine, this was sponsored and supported by work from PEACH, which is led by Dr. Gary Freed, and also the initiatives and work of the Office of Health Equity and Inclusion, was noted that looking at approximately 1,500 adult records at Michigan Medicine, there was a discordance in what patients actually report as their self-identified race and ethnicity, as well as compared to what is actually recorded for them in the medical record. And in the adult population, there was a 6% discordance in race, what is reported by race, and then 4.6 for ethnicity. Then we look at our pediatric patient population, again, sampling 1,500 patients and families, noted that in the pediatric patient population, there was a discordance of almost 13%. For race, and then for ethnicity, the same at 4.6. I will tell you that those who are doing this evaluation shared with me just days ago that this is actually higher than what we initially thought it was, looking at data that they have collected and evaluated from September through September of 2023, noted that the discordance in race is actually up to 22% in our pediatric patient population, simply because we have now expanded the options for race and ethnicity in the medical record. And so in our efforts to broaden the options that are available, there's also correlating with an increased discordance in reported race and what we're actually capturing. So this leads us to what are we going to do to make this better and resolve this problem? So you all have seen this already, the framework for the healthcare equity roadmap that we are working on here at Michigan Medicine, and there's 6 levers of this roadmap, but I want to focus on 4 of them. So culturally appropriate patient care, I've already referenced. Collection and use of data to drive action. I'll show you how that data we've collected at Michigan Medicine is driving action. And equitable and inclusive organizational practices and policies, as well as what are we going to do to hold ourselves accountable and make a difference. And so focusing on systemic and shared accountability. So this is the proposed workflow. Those of you that are familiar with EPIC or our electronic medical record system at Michigan Medicine understand that there's the patient portal, which is their ability, the individual's ability to interface with their medical record. And through the patient, we're hoping that we'll be able to collect and verify real and SOGI data on an annual basis with our patients and families receiving care at Michigan Medicine. The first priority in doing so will be using the patient portal, where the patient will receive a message at the top of the year in January on an annual basis, reminding them that they can go into their information about me tab of their patient portal and update their information as it pertains to race, ethnicity, their preferred language, as well as their sexual orientation and gender identity. They'll also have the opportunity through the e-check-in process. So those of you who have had visits, you know that you can either e-check-in for a in-person visit and as well with a virtual encounter that we're going to implement hard stops in the system where you're going to be prompted to answer these questions. You do have the option to decline answering the questions, but you will be prompted to give a response to those questions. And in some of our facilities, we have the tablets or the kiosk, or what is now a new initiative at Michigan Medicine with bringing your own device, in which when you check in for your visit, you'll be prompted by the check-in staff that you may have some demographic information that is not quite up to date or hasn't been reviewed in some time, so that you can actually go through the process and update it on your own personal electronic device. And for those, we know everyone's not savvy and may not engage with the patient portal. You still have the opportunity with the medical assistant or the care provider that you're seeing to be asked those questions, if you're comfortable with that, to then go through the process of updating that information. So this is just a sample of the new patient workflow going through the system. And you may be asking yourself, why is it that we may be asking individuals about this, and how will we be sensitive in asking this information? So there's a national campaign called We Ask Because We Care that has won national recognition from our partners here locally at Henry Ford, and we are using that same campaign to ask patients of this information because it is important information for us to collect that drives how we engage them in care, and we want to provide patient-centered care. So we'll be using the messaging around We Ask Because We Care to prompt them to provide us with that information. And as I mentioned, every January, this prompt will show up in the patient portal that would allow or remind individuals to review their information. And again, if you do not want to provide the information, you will have the option to select that, and you will not necessarily be asked or reminded when you present for visits, but you always will have the opportunity to go into the system and update it if you so desire. Wanted to provide here the cadence with which some of this information will be collected. Those of you who work in the health system may be familiar that pediatric and adolescent patients have the opportunity to have proxies have access to their medical record. Some of this information, when it pertains to sexual orientation and gender identity, will not be accessible to the proxy because we know that it is a personal matter, and some individuals may not want their proxy to have full access or know these things. And so there's some limitations with who will be able to view that information for our adolescent population, which is going to be those 11 to 17 years of age. And so in terms of systemic and shared accountability for this information, we know that this is critical information that's part of the healthcare record, and other governing systems that evaluate our health system in terms of the work that we're doing and the care that we provide are also watchful about it. And some of those institutions are the American Hospital Association, the Leapfrog Group, CMS, the Loan Institute, U.S. News and World Report, as well as a Joint Commission. And so we've been put on alert, in a sense, that they will be asking for this information. We're going to be held to account for it. How often do we collect this information? How often do we verify this information? And what do we do in response to the data and the patient demographics for those that we serve? So we are being held to the carpet for this, and so we are responding to that. And want to thank you for your time as I was presenting on real and SOGI data, and then my colleagues will be presenting on the social determinants of health.
Thanks, Okayama. My name is Alicia Meyer. I'm the Admin Director of Care Management for UMMG. Thank you all so much for this time to share with you the work we've been doing. So you've already heard this background from Susan earlier, that where you are, what resources you have may impact your decisions around care and how successful that care is. So how can we be proactive about finding out what those barriers are, addressing them before they become a barrier to care? In Domino's Farms pre-op, we had a young mother who was going in for a mammogram, screened positive for several social determinants of health. We rescreened her prior to her visit, addressed those things, got her food, got her access to mental health, connected her with M support, and had a follow-up plan for support afterwards so that she could get her care and continue to receive care that she needed. And that's what that process describes of how do we screen people, centrally understand what's going on, connect them where they need to be internally, and if we don't have the resources internally, connect them externally. In ambulatory care, this expansion plan has gotten about halfway, and as we understand the full need, we've realized that we need to bump up our teams before we continue to expand screening so that we're delivering on our promise of engaging people who have needs. And what does that mean with positive screens? Well, in our last understanding of September, we had close to 3,000 positive screens per month in just those half of the clinics that we have gone live in. So out of the 174 of the over 300 clinics, about 3,000 people screened positive, and October looks like it's even bigger. So there are a lot of people with needs, and we are doing our best to engage them. We have a bunch of resources, so if you are interested in seeing how this process is developing, we have both a SharePoint site linked there as well as a dashboard that's available to everyone with a med.umich.edu email address, and you can see how that is progressing. And that's the ambulatory side. I'm going to give it to Audrey Hudiker for the inpatient side.
Hi, everyone. Good morning. So as Alicia shared, I'm Audrey Hudiker. I'm a manager in the Department of Care Management, overseeing our inpatient social work team. So I want to share with you a little bit of the work we've been doing on the inpatient side related to social determinants of health. In 2020, we were actually lucky enough to receive a grant to start piloting a program to proactively screen patients for social determinants of health on admission to the hospital. We wondered what this might actually show us about our patient population and the gaps in care that we might actually have for our patients that we don't know about. So with that, we were lucky enough after the grant concluded to have that program continued by Michigan Medicine and expanded into M.H.A Children's Hospital. So you can see our screening volumes here. Currently, we're screening about 1,100 patients a month. who are hospitalized at Michigan Medicine. We've found that 22% of the patients we screen have at least one social determinant of health need that we discovered during the screening process. 4% of them have 3 or more needs. So when we think about 3 or more needs, we're thinking about those categories, right? Housing, transportation, social isolation, healthcare financial strain. So a good deal of our patients have these needs for us to address. We wondered what this might actually offer in terms of a benefit to the health system as well, and what we found is that screening patients proactively for social determinants of health actually reduces their average length of stay considerably, as well as their observed to expected length of stay ratios. This sounds like a lot of numbers that really relate to billing and the operations of the hospital, but it also relates to the patient experience. No patient wants to stay in the hospital longer than they need to. We found for M.H.A, that's the left-hand graph top bubbles, that we reduced length of stay by a little over a day. For adult patients, we reduced by a little over a half a day. Our O/E ratios are also significantly reduced, and so what we've found is that proactive assessment really gives us the ability to offer early intervention and prompt a timely discharge for our patients. So what's coming next? CMS is now sharing with us that in 2024, beginning in January, that they are expecting hospitals to screen all patients over 18 years who are admitted to an inpatient status in the hospital. These are the categories that they're requiring us to screen for. So we're excited to work through that rollout. That's coming very quickly. We'll actually be starting that November 1st in partnership with bedside nursing, and then with our care management social work department to address the needs of our patients. Recently also, CMS has recognized the value of Z codes in the inpatient space. So early this year in 2023, we actually amended our documentation in the inpatient space to better capture Z codes. So Z codes are the social determinant of health codes that are bundled with the DRG as a part of a patient's hospital stay. With that, you can see that we've screened over 11,500 patients with positive social determinant of health needs that we've been able to code Z codes on. The Z codes actually give the health system a little bit longer expected length of stay to care for those patients. CMS is acknowledging for us that patients with social determinant of health needs may require a little more time during their hospitalization to actually have a safe discharge. You can see in the graph there the complement of Z codes, our biggest one being housing and economic insecurity. 49% of our patients with those coded Z codes actually are experiencing housing and economic instability. And I will turn it over to my partner, Sue.
Thank you. Excellent. You know me already, and I see we're over time, so I'm going to breeze through this. Our clinical teams, our social work teams do an awesome job of connecting patients with resources, but what if those patients don't want to interact with our teams? What if they don't want to talk about their SDOH with us? They'd rather keep it separate. We have contracted with an organization called Find Help that our staff can use, our clinic can use, but also patients and community members can use to connect themselves with resources. So it's in your M.H.A portal. You can see under community resources, Find Help. It's branded with our logo. You type in your zip code. All of those different categories come up: food, housing, electricity, transportation, childcare. I, in this case, typed in, I think, my own zip code, food insecurity. You can see on there, it will translate this page into 52 different languages for patients and folks to use. It'll bring up a map. It'll bring up every program. You can refer yourself. You can refer a patient. You can send a referral. You can see all the resources that are available. You can pick specific qualifications. I'm a vet. I'm a pregnant person, etc. You can see the next steps, and you can get more details about all the programs that are available. So what have we seen to date? So far, there's been 4,200 searches from our website, from our portal to this website. 1,500 came from our own staff members, and then we've had about 600 connections of a patient with a resource. In our end perfect state, we'd create then a closed loop, where if the patient wants to, if we're working with the patient, that information can get back into their portal. So we saw the patient, they needed help paying their electric bill, we referred them to this resource. That resource or nonprofit wrote back, yep, we helped this person with their electric bill, and the provider can see all that. But if they don't want to, anyone can go and do this on their own, and it's a HIPAA compliant page. So thank you so much.
actually, you all were not completely out of time. We're going to call a slight audible here because it should have reset. You were two presentations together. So if anyone has, we do want to take a moment here and take some questions. That was really data heavy and really great. If you don't mind kind of rejoining me just in case there are any questions. Well, maybe I'll ask first, does anyone have any questions for that presentation? If there are questions, we do have a little bit of time. We could take a few questions. We do have a question, so if our presentation team could rejoin me, we'll take a few questions because we have about 5 to 10 minutes for questions. Do we have a mic, Ashley, for questions? We are grabbing a mic. We are flexible as needed.
Hi, my name is Brooke. I work at University Health Service across the street. I'm a medical assistant. And I know that we are slightly separate from Michigan Medicine. Like we have our own like governing body. We're part of student life. I was just wondering, is there any effort made, and this could be a moot question because maybe it's already underway and I just haven't spoken to the right person, but is there any effort being made to align UHS with Michigan Medicine's DEI 2.0. The only reason I ask is that some years ago when I had applied to be the DEI ambassador for UHS, UHS didn't really have one. They never had one before. And so I was just wondering, is there going to be like a more global effort to get UHS aligned with Michigan Medicine efforts and practices for DEI?
It's not specific, I guess, to that. I think that this is a great question. This is really the purpose of us coming together today. So Nathan Hinkey is standing next to you. Maybe he'll grab your information. We are always looking for partnership opportunities and to be thoughtful about how we can better share resources and opportunities. So I think that is more than possible. So thank you. Are there any questions, any additional questions on the data that was shared and the information? I think it looks like we have a question. Well, we can get a mic. Yep, I see some. And just because of for hearing impairment and the live stream, we want to make sure everyone is mic'd.
Hi, I'm Ruth Bunton. I work in nephrology as an operations manager. So my question was regarding the Ypsilanti Health Center. I noticed on your list of adult specialties, nephrology was not there, despite the fact that you are seeing 43% of your patients are African Americans who disproportionately suffer from diabetes and also kidney disease.
So that's a great question, and it was ranked pretty high in the list of specialties. Unfortunately, at some point we ran out of space, and so we did have to like kind of pick and choose. As we go into the building and more space opens up, we are keeping a kind of a running total of other specialties we should add. And we're also understanding that we can't make sure every specialty is in that building, really trying to work on how we make sure patients who should be accessing that service have access to it. So can we make it more convenient? Can we help with transportation needs? But that is a fantastic question and one that is on our kind of our list of potential future services.
Thank you. I had a question about the inpatient screening. So with the CMS starting to require 100% of 18 and over, what is the percentage now? And by the way, thank you for all the work. I think it's great. I'm just curious what that lift is for January.
Yeah, absolutely. That's a great question. So right now, one of the differences is we've been screening patients of all statuses currently. So inpatient, observation, and OIB, so outpatient in a bed. This pivots our screening a little bit. So our screening of inpatients right now is at 17%. When we subtract out those other statuses. When we add those other statuses back in, we're at about 25% of patients that we're able to screen. We are currently screening about 1,100 patients a month. We have a little over 4,000 discharges a month-ish. That number is really rough, right? Like it moves. So about a quarter.
Hi, sorry, I work at M.H.A in the ED. So I had one question about the proxy. So when parents have proxy, do they have information about all of their prescriptions, including birth control?
So for proxy access, that would be limited, I believe. And I know, Nicole, you're here. You can probably speak to this a little bit better than I. But typically, they do not have full access to the record for those 11 to 17 years of age for proxy access. And so with what I presented around sexual orientation and gender identity, they would not have access to that either. I don't know, Nicole, if you wanted to elaborate given the Roz experience.
I wanted to say thank you, and I'm so excited to have you present to everyone because I work with many of these colleagues, and they're near and dear to my heart, and they align with my mission. So I practice in community health. I think that there's things, even though the proxy may submit some of those things or suppress them, there are other things to be aware of. So if a pharmacy, their emergency birth control or morning after pill, they could call and say your prescription is ready. And so I think even though we have to be sensitive to proxy access, also think about those other entities that might be reaching out to families. And I'm happy to talk with you after if you want.
Yeah. The other that is suppressed also is explanation of benefits for minors. Those are not released on the explanation of benefits either. So sexual health care is not released due to the EOB. Mm-hmm.
I'm sorry, I had one other question, and it was for the Ypsilanti Center. I was wondering, I know they have a PACE program. I saw the social isolation. Are you partnering at all with like any of the, like a PACE program, anything like that, that would help elderly adults?
It's a great question. So I think part of this work is identifying all of those areas where there are significant SDOH needs that maybe we don't, as a health system, provide ourselves, and how do we work with community agencies to try and connect patients to those resources. And I know Alfreda's team is constantly doing that, but as part of this project, looking at those as well, because social isolation after food insecurity is our #1 SDOH need.
Just to add to that, if it's possible, Alfreda, would you like to speak a little bit to the work that CHS is doing with the social isolation in the elderly?
So social isolation is also one of the priorities for our Unite team, which is who does our community health needs assessment. And so we have our Ypsilanti Meals on Wheels program and our Ann Arbor Meals on Wheels programs that have daily folks who are going in and calling. Our Turner Wellness Center, they had, especially during the pandemic, phone calls. There's also agencies like Jewish Family Services that has friendly visitor programs, and as well as some of the senior centers that are now in Ypsilanti, Ann Arbor, and other areas are all working on and looking at how we can bring more folks in, our older adults. And there is a brand new program I heard about where it's electronic, where folks can have a tablet and have everything pre-programmed in. So it's in pilot right now, but they have some really good baseline results as of now. Monday when we were talking about it. So.
I'm seeing a few more hands, but I have a question from the live stream that asks to go into further detail on Z-scores and how those are implemented.
How they are what? Can you repeat that?
How those are implemented.
Yeah, so Z codes, like I said, are the DRG or ICD-10 codes that relate to social determinants of health. Those codes were implemented, the way that we capture them, it's actually after a patient discharges and it has to be run through coding software. So the way that we were able to capture that was aligning an element in the documentation of our social workers that pairs close enough with the Z code that it's recognized by the AI software in the coding tool to be picked up and reliably then translated back into the coding on the admission.
Good morning, Stan Kent. I'm the Chief Pharmacy Officer for University of Michigan Health. Thanks for your presentations. My question is about the Ypsilanti clinic, and if you know the pharmacy that's at the existing clinic will be moving. That's one question. The other is, as you all know, medication access is becoming more difficult because they're more expensive. So can you tell me, Susan, if there's any work being done to help address that?
Thanks. So the current pharmacy that's in the building is not moving. The building we're in now, we also, Packard Health is also in that building, and so they're going to maintain their presence there. We'll have like PharmD services in the building, but we're not going to put a Michigan Medicine pharmacy in. As part of the work of really trying to spur some economic development in that neighborhood, we wanted to make sure that we weren't competing with locally owned businesses, and there's a few locally owned pharmacies on that same block. So, but it's my understanding that a local pharmacy may be going into that building. In terms of prescription affordability, one of the things we plan to have in that building is space for different disciplines and folks to come in and help our patients with different things, signing up for benefits, maybe working through financial need, other SDOH needs, other trying to pay for their healthcare needs, so that they can do it right there while they're in the clinic. And I'm sure there's probably other work around that as well. Specific to that building, we plan to have space.
Hi, I just wanted to know how much the patient portal is used by disadvantaged communities and whether that plays a role in health disparity.
You have a great question, and we know that technological access varies across various groups, age groups, as well as race, ethnicity. Looking at our health system data, portal use is most prevalent amongst those that are 18 to 45, 50, and then there's drop off as you get into older patient populations. And so we are very aware of that and try to make sure that we have other options for ways in which they could be able to engage in care. For example, our virtual care teams will offer support for individuals who are not portal savvy in advance of a virtual care visit, if that is what they're scheduled for. And I know Alfreda's team, again, has done some work around being able to provide technology support for seniors, even with the public and local libraries. But in all of the workflows that we are developing, although they may rely heavily on using the patient portal to offload some of the weight that we have on our clinical care team providers, we are very cognizant in trying to develop secondary workflows for those that are not portal savvy or don't use the portal. I don't know, Alicia, if you have other things to add to that.
Thanks, Okayama. For example, one of the processes, so Okayama presented about the SOGI and real data and how at the last point it's within the visit that things are collected. Similarly, when we work with proactive outreach for SDOH and ambulatory care, the majority of people also fill that out. Like it's about 50-50 people fill it out during their visit. So it's not necessarily reliant on the portal. And one of the 3 of the questions that we ask there also is, do you need help with virtual care? So do you need help connecting to the portal, et cetera? And those are referred directly to the virtual care support desk.
I want to thank our presenters for bearing with us with that audible that was not planned. So I thank you all so much. I appreciate you. And so we have one more presentation about traveling the health equity or traveling the roadmap. And so I would like to invite the presenters for the Health Equity Consult Service to come to the stage now.
Wow. Good morning. Such a pleasure to be here today. My name is Samantha Gaia. I am a social worker, but also program manager for our Health Equity Consult Service. I'd like to introduce a couple of my colleagues here as well.
Hi, I'm Priyanka Shaquille Brown. I am also one of the program managers for the Healthcare Equity Consult Service and a social worker by training.
Kamal Ayubi. I'm staff chaplain, program manager with these great people.
All right. Again, just so thankful to share this space with you all. There's just so many amazing things happening across the U of M community, and we're just pleasure to be here to share a little bit about our work here with the Health Equity Consult Service. So as you see here, I have 2 program manager colleagues that support our work, as well as an entire team that we'll get into today. As we talk about the inspiration for our service, we really have to honor the legacy of Dr. Susan Moore. During the height of the pandemic, she's actually one of our own U of M medical school alumna. And during the height of the pandemic, she was a practicing physician in Indiana. She was admitted with COVID-19 complications to her local hospital. And she unfortunately shared her experience with us on her social media platform. She shared that her experience was colored by racism, by biases. She shared that she had to prove something was wrong with her in order for her to get her care treated. She was in so much pain. And unfortunately, she was discharged and then readmitted to another local hospital and died from her COVID-19 complications. We also want to recognize this is at a time where there was so much happening across our nation, lots of community uprisings, lots of just social unrest considering the violence that was happening as well during that time. And again, we also want to be aware of the disproportionate toll that COVID-19 had on historically vulnerable and marginalized populations. And let's also highlight too, Michigan Medicine, we are amazing. We are the leaders and the best, but at the same time, we aren't immune to any of these concerns. We don't necessarily live in a bubble when our patients and families show up and get their care here. So we also have shown, just an increase in reports of discrimination allegations here at our hospital that, our institutional leaders took this as a call to action. They took these events and they said, we have to do something about this. And with that was the inception of our Healthcare Equity Consult Service. And I do want to add, a lot of those leaders are a part of our consult service and in the room as we see here. So we're among friends, and that's definitely welcoming. So the approval and socialization of the Healthcare Equity Consult Service came from, all of these departments that you see here. Our own Office of Health Equity and Inclusion, our leadership through our children's and women's hospitals, as well as our adult hospitals, executive nursing, social work, spiritual care, our Office of Clinical Affairs, just to name a few. Again, this really, really speaks to the collective effort to bring impact, change, and health equity at the bedside, again, with a focus on clinical interventions and interpersonal dynamics, which ultimately we do hope that can create some opportunities for structural or systemic changes using these clinical interventions. So it's kind of weird looking at your picture here, on a screen, but, just to show the organization of our Health Equity Consult Service. Again, as you see, we have our 3 program manager colleagues, including myself. Dr. M.H.A, who just spoke on behalf of her work, is our medical director, and we also have Christina Wright, who's somewhere here in the audience, over there in the back, who serves as our administrative support, and she's also the associate director of our spiritual care department. So again, in addition to the work that we do as the leadership team, we also have an entire consult service of interdisciplinary professionals, of one of whom I see here today, Carol. Nice to have your support as well. So executive nursing, internal medicine, patient relations, clinical risk is, again, our Office of Health Equity and Inclusion and our ethics consult service team members. And in addition to our consult service, we also are backed by the support of an advisory council, and we have support from Community Health Services. We have Alfreda Rooks here in the audience. We also have, again, support from our Office of General Counsel, Human Resources, Organizational Learning. Again, I could probably go on and talk about the amazing work that all of these folks are doing that help guide our practice here at bedside clinically with our patients and families. So the objectives of HECS, and HECS is just short for our Health Equity Consult Service, is really to align with our base initiatives and improve our belonging, access, safety, and experience of our patients who seek care here. And again, like I mentioned, our service really uses our clinical interventions to really drive structural and systemic changes. And we want to align the care that we're giving our patients as providers with their experiences, especially those of historically and marginalized populations. We elevate their lived experiences. We want to validate them, making sure that they're feeling heard and valued and respected in their care here at Michigan Medicine. So a little bit about our workflow. We are currently an inpatient service. We operate from Monday through Friday, 8 a.m. to 5 p.m. And we actually currently have we're in the early planning phases of expanding to our Ypsilanti Health Center. So again, thankful to see folks here in the room talking about the great work of that new expansion of that building. And we also have a confidential option for our consults. So you can consult us via the M.H.A for those who are aware of our medical record system. You can page us in the system. You can also send us an email message. And sometimes our colleagues are, familiar enough with us where they can just shoot us an, informal message, and we can always touch base from that way as well. So again, we recognize the sensitivity to our work, and we want to honor that and also respect that folks really do want to share if there are any concerns that they're seeing in care. So we want to honor that confidential option of being able to disclose those concerns for us to follow up on and provide appropriate interventions. So once we get a consult, typically what we do is really get the information from that referral source to understand the dynamics that are at play. And then from there, we'll talk to any folks that are involved in the care, whether that be the bedside provider, the nursing staff, or sometimes on a case-by-case basis. We don't necessarily meet with our patient and family directly, although most of the time we are doing that to make sure we are elevating their concerns and their experiences. But a lot of times we recognize there may be some harm with that, and we do want to have some collaborative efforts with our providers behind the scenes to really coordinate what's going on. Is it a systemic concern? Is it a pattern that we're seeing across maybe multiple providers or multiple disciplines on the unit, and how can we approach that from a different angle? And finally, we do offer some recommendations in the medical record system. And then again, sometimes, like I mentioned, if there's more coordination with our providers, we can give those recommendations in real time and be able to offer support and guidance to their work. We're actively conducting an evaluation for our pilot phase. I should have mentioned that in the earlier beginning slides, but we actually had a pilot phase for our health equity consult service last year that launched in August. So we are just over a year in working progress, and we were permanently funded as of April. So we are doing an evaluation of that pilot phase from August up until April to really get an understanding of the impact of our work and what that translated for our patients, families, and providers. And then lastly, we'll talk about this a little bit more, but we do identify any system policies or structural opportunities for change, again, using a targeted approach of our clinical interventions that we're seeing on the floor. So we are just over 100 consults now. So over the next few slides, we're going to talk about some data to date to share with you all. So again, we just reached actually over 100 consults since our inception last year in August. We have been able to partner with so many departments across the health system, whether that's our pediatric specialties, our critical care ICUs, our psychiatric departments, even oncology, and in so many different areas across the institution where we're bringing these new conversations of health equity and implicit biases, again, that we all have, and we all, experience the world in so many different lenses and, based on our journeys as humans, right? So we want to bring that education to the bedside. We want to also show what that looks like and how that translates to someone's care. So again, talking through some of the data. So we're collecting data on so many variables across the work that we're seeing. We're just going to highlight a few again over the next couple of slides. So as you can see here, we have gender identity. We have most of our consults, over a majority of our consults identifying as female. Again, over a majority of our consults are those that are identified as Black or African American. And then here, ethnicity, we see that majority of our consults also are identifying as non-Hispanic. And we do want to share that there is a known disparity, as some speakers have shared, with our collection of patient-reported race and ethnicity. And here we're showing variables across insurance type, spiritual affiliation, as well as preferred language. So majority of our consults, again, are for patients and families who have a public payer source for their insurance. We see that Christian here has the majority as well of self-reported spiritual affiliation, and then majority of our patients are preferring English as their primary language. So who is requesting a HEX consult? We are seeing that a majority of our consults are coming from staff and faculty. And this really, really speaks to our efforts of being a highly reliable organization. So when you see something, you're speaking up, you're bringing that concern forward, and now we're this new avenue to talk about what implicit biases look like at the bedside. How can we improve them? How can we use our own interpersonal dynamics, the way that we know how to treat each other as humans, to be able to improve healthcare outcomes? And here are just some themes that we've seen to date. I could probably talk about these all day, but for sake of time, I will just highlight a few of them. Again, race is over a majority of our consults have some kind of racial implicit biases associated with them, whether that's related to CPS filings, whether that's related to security interventions, or even medical mistrust, as you see here just next to it. Again, there's communication and language barriers that speak to a lot of our work, gender identity, and mental health and substance use that we know come with some stigma as far as their diagnostics and their care that they receive in the hospital as well as in the community. And lastly, just to share a little bit about our institutional impact thus far, we are so honored to do this work again alongside everyone here, and the partnerships that we have been able to grow is just astounding. So thus far, we've been able to impact education and training with our partnerships in Office of Health Equity and Inclusion, with our medical school, and also with just our staff and faculty providers that are doing work on the floor and in their own spaces. So we've been able to really collaborate with them and partner with using the work that we're, again, seeing on the floor to speak to the education that we're providing to our staff, faculty, and learners. We also have some partnerships with the Division of Public Safety and Security, so our own U of M security team, as well as our Workplace Violence Department. We recognize there could be a lot of biases as we interpret behaviors at the bedside, and we want to be able to make sure everyone's safe, emotionally, psychologically, physically, and be able to speak to where biases creep up in those assessments, as well as the interventions that follow them are very impactful as far as, really moving forward with the health equity lens and also health outcomes and experiences here at Michigan Medicine. We also have some partnerships with our adult leadership team in reviewing and commenting on patient care plans for our patients that do have a little bit more higher utilization here at our institution. We want to figure out what is going on. And again, as we highlight these patients and their needs, we want to do that in a way that isn't further stigmatizing, that doesn't come with additional biases, especially when a lot of the social determinants of health can impact and show up at the bedside here at Michigan Medicine. And lastly, we have really been honored and also amazed by the work and how that really improves our own policy and practices here at Michigan Medicine. So there have been a couple of instances where we've been able to speak to our visitation policy and making sure that it's represented consistently and accurately for our patients and families getting care here. We've also been able to speak to our meconium screenings for our newborn population. We know there's a disproportionate amount of drug screenings for our newborn babies on Black African-American women. So being able to ensure that the policies and the order sets for those things are accurate and, again, consistent with the policy is another way that we've been able to speak to equitable delivery at the bedside. So, oh my gosh, I feel like I just talked so fast. But so, again, thankful to be here on behalf of our entire team, our consult service, our advisory committee, and our institutional leaders that continue to support us in this work. As we know, it's a journey. It's not just the light switch that we can turn off, but some ongoing work that it takes to really collaborate, collectively as a U of M community. So please feel free to reach out to us via email. We are all a message away, and we just look forward to continuing working with you all.
Can we please give another round of applause to all of our presenters? So now we have a break in our agenda, and so we'll be back at 10:50 a.m. around that time to introduce the leadership panel. And so while the presenters are still here, I would encourage you, if you have additional questions, feel free. They're all over here. Feel free to accost them and talk with them on the side. Also, talk with each other at your tables. Again, we want this to really focus on collaboration. Think about how you all can collaborate with each other at your tables, or also think about how you can collaborate with us and the things that you've heard today. And so we'll take a break, and we'll see you all back around 10:50.
All right, if we could come back to our seats. I hear so much wonderful and robust conversation, but we're going to begin to get started with the next part. I was so excited about the collaboration I was hearing during that time. And so we're really, really excited about the next part of our panel. It demonstrates an institutional commitment to diversity, equity, inclusion, and health equity as not only a part of the work of any one office or any one team, but as an institutional priority that really permeates, as we heard in our earlier presentations this morning, every part of our work, our safety, our quality, our experience, our research, how these things show up. And so we're now moving into our leadership panel that are going to speak to how these institutional priorities are aligned to this health equity work. And I'd like to welcome our moderator, Dr. Versha Pleasant, to join me on stage, as well as all of our panelists. So I will call their names. We are not going to do their bios today because they have such extensive CVs, but what we will do, there is a QR code in your program that has all of our speakers' bios if you'd like to learn more. And so would you like me to introduce the panel, or are you gonna call? I will call up our panelists then. I'd like to invite our Executive Vice Dean for Clinical Affairs and President of Health, Dr. David Miller, our Associate Vice President and Associate Dean for Health Equity, Dr. David Brown, our Chief Environmental and Social Governance Officer, Tony Denton, our Executive Vice Dean for Research and Chief Scientific Officer, Dr. Kunkel, our Chief Quality Officer, Dr. Brooke Watts, and our Executive Vice Dean for Academic Affairs, Dr. Deb Weinstein, to join us on stage. You do have a QR code in your program for questions. We want to make sure to get your questions. We'll be asking them at the end, but we are excited if you give all of our panelists and our moderator a warm round of applause, and we will get started with our leadership.
Can everyone hear me? Ooh, yeah. Hi. I am so incredibly honored to be on this stage today with such an illustrious panel of individuals. My name is Versha Pleasant. I'm a clinical assistant professor in the Department of Obstetrics and Gynecology and director of the Cancer Genetics and Breast Health Clinic. Thank you all for being here today. Thank you for having me. We're going to start the panel with a couple of questions, followed by a Q&A from the audience. Academic medical centers face competing demands: political, organizational, technological, relational, working with vendors and community partners, and working to support the needs of learners, patients, and employees. There are a lot of challenges. So I have a question for everyone on this panel. In about 2 to 3 minutes, please share how you have shaped diversity, inclusion, belonging, and health equity in your sphere of influence as a senior leader in our academic medical center. Dr. Wade Golden talked about shifting the culture. How have you shifted the culture? Maybe we can start with Dr. Weinstein, and then we'll go down the line. Thank you.
Great, thank you. Thanks for that great question, and it's a privilege to kick off this discussion. So I've only been here a little bit less than 2 years, and anything I'm going to mention is the work of the community that's been leading up to this for a longer span of time. The way I think about DE&I is it's not a topic that we turn to and we have to address, but it's a lens that we look through as we turn to everything within our sphere of responsibility. It's a way of thinking and a way of being and acting and all of that. So when I think about education, the big areas of attention are how we recruit and select individuals for our UME programs, our graduate programs, residency and fellowship programs, and also leading onto our faculty as well. It's how we welcome people and make sure that they feel like they're supported and like they belong. And it's how we think about our curriculum and look for areas where we have to improve because there may be structural racism built into medical school and other curricula. It's how we assess people, and our new Senior Associate Dean for Medical Education, Lou Edgy, recently co-authored a monograph on bias in medical student assessment, which is critical to think about. In the faculty area, some of the same themes come up, and in addition, as we think about promotion and tenure, looking again for structural barriers. Are different areas of scholarship and research valued equally or appropriately? That's something we have to think about. And then as we recruit leaders and we appoint people to leadership positions where they themselves have influence of how things move forward, we have to think about how to get diversity into not just our clinical leaders, but our administrative and educational leaders. And I think we're making real progress there. And again, thinking about structural things like term limits, where we are actually getting more intentional about that, because that opens the door to new ways of thinking and more diversity. I'll stop there.
Thank you. I'm David Miller. I'm the president of the health system, and thanks very much for the opportunity to be here this morning. And I think this is a very important question. From a clinical enterprise perspective, we're a very large organization. If you look at it by number of employees, or you look at it by how many health systems measure their top line revenue, and now with our expansion into Lansing and Grand Rapids. And so the degree to which we can represent diversity, equity, inclusion, belonging, health equity in an organization as big and complex as ours, from my vantage point in terms of that sphere, is to make those explicit, focused, and part of the priorities in the work that we do every day. And in some ways, that has been the concept behind the base framework, with the B, or belonging and inclusion, as the first element of that base framework, because efforts to enhance access, safety, and quality experience, or strategic growth and partnership on behalf of our patients and the communities we serve, is predicated on that first B, that sense of belonging and inclusion. And so those explicit priorities, those efforts to improve in terms of both measured performance and experience in the organization related to belonging, are very important. And so starting in this role just less than 3 years ago, one of the key concepts was, well, how do you comprehensively or at least meaningfully think about a concept like belonging and inclusion in an organization as big and as complex and as diverse as ours? And a couple themes emerged. First was, we could see in our employee engagement surveys that team members provided different responses and disparities in responses to questions around our organization valuing faculty and staff from different backgrounds. They differed by race, differed by job classification. And so we had to ask, how do we start to identify factors or ways we can improve that? And we talked to our employee resource groups, we listened in the organization, and we've now implemented with guidance from our team members, for instance, mentorship programs that are focused on emerging leaders, creating new opportunities in the organization for under-recognized leaders in the organization. So making them explicit. With health equity, similarly, our second belonging priority is to address specific identified health disparities in hypertension management and in pediatric flu immunization, and then unleashing our focus, our energy, our resources to address those. So in the clinical enterprise, it has been to make key areas explicit, part of our priorities, part of the work that we do every day, incorporated and connected with our patient care and our care for our communities. Thank you.
Thank you for inviting me this morning to represent the research which is being done at the University of Michigan Medical School. We are in the third rendition of our research strategy, which we just launched. It was called Great Minds, Greater Discoveries. And the first strategy is all about the people, that we want to be a destination not only for our faculty, but also for our staff and learners. And along with this comes the culture and the climate that is set up in each and one of our individual laboratories, which basically have miniature ecosystems contained in this. And we know that DEI needs to be driven down to the laboratory level. So we launched what's called the Research Climate Council. This is a committee which is populated not just by faculty, but it has student representatives, our learners are there, and it has staff representatives. And I can say that some of the most vulnerable individuals that work at the University of Michigan are found in our individual labs. And what we wanted to do was to assess what is the culture what is the DEI climate at the laboratory level? And we found through assessing this group is that often it's the small things that really make a difference in turning these cultures. Having lunch together, sending a thank you email, having someone in the lab join all of the individual laboratory meetings that occurred. So we have made a conscientious effort to reach out to our laboratory faculty, learners, and staff to understand how can we improve that setting to make it one of the more comfortable settings one can work in here at the University of Michigan.
Good morning. I'm Brooke Watts. I'm the Chief Quality Officer. I'm very pleased to be here with you today. So I get to measure quality for the system, and let's just agree that we agree you cannot have health equity, you can't have quality without health equity, right? You can't have quality without health equity. So if there's members of our community, if there's members, our patients that receive care that's different because of one of these characteristics, can't have quality, right? Agree, okay. So how can we help? What do we do? Well, we focus. So first things first, like where do we know the gaps are? And we have identified 2 critical gaps in our care that are part of the BASE initiatives. These were not, pulled out of the air. They represent real, true gaps in the clinical care that we provide that we can address. So there are very concrete things that I believe that we all can do every day to help close these gaps, and that's why we've picked them. But if you ask me what really keeps me up at night and thinking about health equity and quality, it's that we only know what we know, right? We measure certain things, they don't represent the holistic approach to structural racism. And so when we look at our data and we can tell you we have these things, we have a handful of things that need to be addressed, what keeps me up at night is learning and thinking about how we measure all the things that we know that contribute to poor health outcomes in our community that we don't measure. And it would be a lot of fun to talk about that a little more later. Oh,
I have mine.
yes, sir. He has it.
You've got yours. Good morning, everyone. I'm Tony Denton, Senior Vice President and Chief ESG Officer, previously the Chief Operating Officer for about 20 years. I would suggest, though, the sphere of influence, at least for me, it starts many, many years ago in thinking about servant leadership. The importance that we speak to when we think about how we help each other, how we are patient-centered with an intention of having everybody seem to receive the right care that they deserve, and engaging in conversation around that. However, in the evolution, I guess, of me, I'll call it Tony 10.0, you learn a lot along the way about the importance of listening and acknowledgement and coaching and teaching. And for me, the sphere of influence is both internal and external. Working with partners, David Brown, Kristen Howard, Alfreda Rooks, David Miller, all the Michigan medicine leadership, to adopt a framework and a philosophy that this is so important, that it's not about each of us as individuals, but how we work together in order to move farther, faster. And so for me, that's about communicating and advocacy, creating a roundtable idea around collaboration, bringing the right parties and stakeholders to the table, and being a catalyst for the conversations that are necessary to advance our goals. And in doing that, I believe it ties to community, both internal and external, and then we measure together, and we learn and grow together. For me, that's the mark of progress as to how we work together, and so I engage a lot of dialogue in that space. Serving on boards in the community, food insecurity, Hope Clinic, places that matter, focusing on going where people live and play and pray, and having that be a part of the dialogue as we try to increase our presence as Michigan Medicine. Those are pillars that I'm working on, but also the investments in people. As we think about education being one of the pathways to income, to economic health and wealth and choice, that also then leads to better choices about health, that I think then ties back to Brooke's comment about quality. So Great to be here. Thanks for the invitation.
Thank you so much, Dr. Pleasant. And I just want to first acknowledge the people on the stage. I mean, we have all three executive vice deans. We have our chief quality officer and our ESG. I mean, this is incredible and just shows how much our leadership is committed to this. And so part of the way I center myself is I try to center myself within their spheres and have an opportunity to be a part of the conversation and influence. Additionally, I have to center myself in other areas, and part of my work is the collaboration and building trust with everyone out there in the audience at Michigan Medicine to be the voice for their concerns, and also to help center DEI for the work that they do as individuals and as teams. I've always felt this is a collaborative effort, and I've said that from the beginning, and when I look out here, I see all of my collaborators. These are all my co-authors, even if they only allow like 10 on a paper, all of you are the co-authors. Also, one of the great things about the honors of leading the Office for Health Equity and Inclusion is that we get to do innovative things. We get to do things that we need to do, but we haven't done. For example, Kristen mentioned about the Youth Summit, but that's leading to a K-12 program, something everyone talks about that we should do, but we are going to do it, and that's the difference. Also, it gives us opportunities to be innovative. The Health Equity Consult Service, instead of us just learning and becoming aware of bias, let's figure out how it shows up in the clinical space and do something about it. And also to our great moderator here and leader in breast cancer research program that we developed years ago, the Health Equity Vision Clerkship, to try to figure out how to bring diverse individuals here at the same time of respecting our state laws that don't allow us to target individuals. We just targeted her excellence. And she came here as a I don't want to make her cry, but I'm so happy you're here.
This guy. All right. Thank you, Dr. Brown. I'm on stage today because Dr. Brown asked me to be, and I've been working with M.H.A, Ashley and Kristen to prepare me for today, and so I'm just really grateful for this opportunity. So Dr. Brown and Dr. Watts, you all held a little carrot in front of my face with the way that you ended your talks and talked about how do we translate what we know into actual clinical care and clinical action. Kristen Howard said this earlier. She said, how does data drive action? Great question. Dr. Caird said, how do we discuss racism and bias embedded within our healthcare system? So I want to give you a little story. There is a popular tool that has been used across the country in obstetrics and gynecology called the VBAC calculator, which estimates the chances of success of a vaginal birth after having had a prior cesarean delivery. It incorporates a race component in a way that is unethical and non-scientific and may change our clinical counseling to patients, particularly patients of color. So leadership within our department, Dr. M.H.A, others leading in the DEI space, our chair, Dr. Dee Fenner, we all collectively decided to discontinue the use of the race component of this tool in our department. So that is a way in which we took the racism and bias and tangibly created change in our department, refusing to continue to use this tool that was racist and unacceptable. So my question, and I'd actually like to ask Dr. Miller, Dr. Watts, Dr. Brown, can you give any other examples of initiatives throughout the hospital in which departments are addressing racist and biased clinical models, calculators, that can negatively and directly impact patient care?
Thanks, Dr. Pleasant. It's great to see you on the stage, and I had the chance to learn about your incredible work at the OBGYN picnic this summer as well, so that was it's very nice to see you. And this is a very important question, and I think I think Michelle and Maria are here, and this has been a topic that has been an ongoing part of conversation broadly in healthcare delivery here at Michigan in many different forms, including with the Anti-Racism Oversight Committee, and has been considered in the context of many different clinical specialties and clinical conditions. And you referenced vaginal birth after cesarean section as one example, and there have been others where the historical incorporation of race in a clinical calculator that leads to different clinical decisions or resource allocation or outcome that have been very substantive. And another one that has been highly visible and very important in our organization has been estimated GFR in transplantation. And in fact, I've been in a number of forums recently where the work that has been talked about by our transplant center and the changes in access to organs because of fundamental reassignment of where you are in terms of progression of end-stage renal disease and access to transplantation has been profound in terms of differences in access. In the amount of work that has been done by the transplant team in that space to go back and review records over many years and lead to changes in prioritization on the transplant list has been, a truly remarkable story and reflection of the exact same sentiment that you mentioned, a refusal to accept what had been wrong in the past and make it and try to make it right today. So I think that's another very clear example that I think is a point of important collective pride in our organization.
It is the hot topic, and it should be. The reality is the models that we use in healthcare, as Dr. Miller pointed out, they come from our data, right? And it's not just clinical data. It comes from all kinds of data points, and where the data is racist. This is a fact. There's an amazing book called Weapons of Math Destruction. Has anybody read it? Who does not want to read a book called Weapons of Math Destruction? Come on. Doesn't that pique your interest? But it really is about how the models can help us propagate inequities in healthcare. So an example that I have that Carlene and I just had a very in-depth conversation about right before this meeting is the no-show model. And I think many of you probably are well aware that the original no-show models were overtly racist. Does everybody knows that? Yes, okay. So the first models were what you did is you used the model the way they were structured to identify people who are at high risk of not coming to their clinic visit. Then you overbooked that clinic to lower your no-show rate. So what happened? People who are most vulnerable, even if they did show up, got less time with the physician. The schedules were crowded. So the EHR vendors, I give Epic a lot of credit. They went back and they removed race factors. They tried to look at them intentionally with this lens that we're talking about today. But the models are still out there, and everyone's been very reluctant to use them. I had the opportunity at my prior institution to do a project around using the no-show calculator to close gaps for disparities. So this is where you come to hope. What can we do? So, all right, we've said that maybe the models are good at predicting no-shows. So is the answer to overbook those patients? What about if we call them? So what we did is we went to our primary care clinic. We used the model, the current Epic no-show model, to identify patients who are at high risk for no-show. And then we did targeted intervention to say, are you working? We call, are you working? Do you need another time? Do you have transportation gaps? And what we saw when we used the model that way, and there's a paper in JGIM from earlier this year, is that we were able to close our gap in no-show. And in fact, it seemed to help patients of color the most. So the opportunities are there. We just have to be intentional about the use.
Yeah, thank you. And I'm greatly appreciative of the Anti-Racism Oversight Committee for bringing this up as one of the, or I believe there were 16 bullets in their, either 13 or 16 in their original set of concerns. And since that time, we've eliminated the vast majority of our race-based algorithms, most of them within the first year after AROC started. Just wanted to make sure we're doing it in a safe way. And like Dr. Miller stated, a lot of our teams have paid close attention to this, and I just recently learned in a Zoom meeting yesterday that for our GFR for patients who are receiving like transplants, once we stop doing that Black patients were more likely to be on the transplant list. So the race-based algorithms were racist. The other thing is that race is a social construct. So how is this kind of medically related? And I'm going to relay a story. Hopefully he doesn't mind. Maybe he's on the Zoom. But the best way that someone kind of explained it was Matthew Wixon, Dr. Wixon, who's like me, biracial, and most Black people are not like 100% Black. He's like, I'm biracial. Is my kidney black or white? Are they filtering black or white? I mean, what sense does that make if all of us who are considered this diaspora of Black are put into one box? And that is a way of caging us instead of allowing us to thrive.
Those were great responses. Thank you so much. Another question for Dr. Weinstein and Dr. Watts. We know that achieving health equity and eliminating health disparities is directly tied to quality and safety. How are we empowering and educating faculty and learners throughout our system to make these connections in a data-driven manner and to speak up in areas where these disparities may occur in care?
Thank you. That's also a great question. I think the first thing that we have to address is education and awareness, because we have to be looking for these kind of outrageous lapses and recognize them in order to then call them out and address them. And some of this, I think, we've gotten so used to hearing these or seeing these things that are wrong that they're not always, in flashing lights the way they should be. So we have to educate people. We have to elevate our expectations of what's acceptable and what's not. I mean, I have an example where I was in a presentation and a comment came, out of the podium that was completely unacceptable. And I looked around and you could see some people reacting and others, I think, maybe they were doing email or something, but it may have been in this vein of, you get used to things we shouldn't get used to and we shouldn't accept. So education and awareness. And then the next element is mechanisms for reporting and calling out these issues and comfort in doing that. One of the obstacles perhaps in getting people not just comfortable but motivated, because I think we have a lot of mechanisms in place here, is that people get a sense of nihilism. Well, I know these things are getting reported and nothing's being done. And in the area of sort of culture and behavior, a lot gets done that doesn't get broadcast because of confidentiality issues. So I think we have to be encouraging and in ways that are, perhaps anonymous or de-identified, let people know when actions are being taken. And then the third thing I'll mention is in terms of health equity in clinical practice, we have to be in the spaces where the equity issues are coming up, and we have to have learners in those spaces so that they can be alert to them and report them and address them. And so if a medical student or a resident's in a clinic where every patient is able to show up because they have transportation, and every patient fills their medication because they can afford to, they're not going to get facile in recognizing and addressing those issues. So we have to make sure that all of our learners are in, and David and I have talked about this a lot and are starting to work on it along with others, have the opportunity to care for diverse populations that have challenges that, that they can learn from and they can help address.
So a couple things. So I think there's two, my brain is on two sides of this. So one side is just the safety, which is, I think, very much in alignment, and people who know me know I don't really like the term high reliability. Don't throw things at me, okay? But maybe you like it, maybe you don't. But what I take out of it that is a high reliability principle that is important to this conversation is psychological safety. and the idea that anyone can raise a concern at the moment they see it. I like the language that we cussed. Does anybody know the cuss frame? Okay. So there's a framework that says, I'm concerned, I'm uncomfortable, I think this is a safety problem. It's just a framing of language. And I would like us to create that space. I think we're on a journey to create that space where everyone is comfortable with speaking up that moment, this, I'm concerned, I think this might represent a bias. I think you might be, this might be an unconscious bias for you. That assumes positive intent, but gives the space to ask the question. So that to me is probably the most important thing. And I do think that comes from our culture work, even though I'm making a joke about high reliability. And then the second part within that, and aligned with it, is this space of quality. And the challenge we have in quality, and I think it gets back to your question, is we only know what we know, just as I said earlier. And I feel very uncomfortable, I'm using my language, very uncomfortable, that we are not yet to a place where we're measuring the things that may be most meaningful in helping to close equity gaps in our healthcare. And let me just give you a quick example. I was very upset, as some people know, poor Dr. M.H.A, I think, talked to me the day after I would read it. There was a really interesting paper on access to CAR T therapy, and the idea that, so CAR T is this amazing, new, expensive treatment for lots of things, but who gets CAR T therapy? Well, it's people who get in to see it to a hematologist that prescribes CAR T therapy. So who navigates the system to get into that clinic to see that patient, to get that patient the therapy? And there's just this incredible gap. So how do we know what's coming? What are we missing? Or the transplant example, which was just in the literature, and also that, the folks that get engaged with care, can proceed along and get the kinds of things they need. But how do we make sure that the system is equitable from the get-go? And that's the part of the data that I think is still, again, keeps me up at night.
It keeps me up at night, too. I was just speaking to our colleagues at the Health Equity Service, Consult Service, about a situation where a resident and I witnessed a patient that was undertreated for pain due to a language barrier. And this resident felt empowered to speak up, and I encouraged, we both saw the inequity and the bias that was happening, that was actually physically impacting this person's care, and we both spoke up. And I think that there's a hierarchy in medicine, unfortunately, that still persists. And I think as leaders in the community, we also have to remember and recognize that hierarchy and empower our learners, our students, residents, to speak up when they see something that is not right. We're excited to see, this next question is for Mr. Denton and Dr. Miller. We're excited to see an expansion in how we envision and support health justice. How will the creation of the Chief Environmental and Social Governance role greater support health equity and health justice? We'd love to hear some specific examples, if you could, from this body of work, as it is new to the academic medical space.
I'll start, David. This role, while titled new, is not new in terms of what we've been working on for so long. I've been working in community service for a long time, because I think it's so important that we go beyond what we just do on a daily basis, but reach out to those who we serve to understand better what they need. And so through Community Health Services, which has been here for a long time, led by Alfreda Rooks, the framework for identifying the needs of the community through our needs assessment, which is a triennial cycle review that leads to priorities. Those are things that have been in place for a while. What's different? Since I said I've been doing that, and also environmental sustainability with regards to our many different recycling, reuse, repurposing programs that speak to trying to improve planetary health. David Miller and I had a conversation about the pivot point, that's what I call it, an inflection in terms of where Michigan Medicine, U of M Health should be going, with the intent that we need to be more intense in our efforts to elevate these things that are more present in our community. And we learned something. I think many of you know this story. During the early months of the pandemic, when there was concerns about vaccine, first the availability, and then who was going to take it first. And so the hesitancy period led us into some important conversations, webinars, town halls, but a discussion about we need to do something different, which was to just sit and listen. So an invitation was made to a ministerial alliance of community area clergy, and we said we want to just hear what we're doing and how we're doing it, what we're doing well, what we need to improve. The response was gratefulness for having world-class health care in the backyard of the community. However, Michigan Medicine U.of.M. Health could be more present. And that term, we took a while to unpack, to figure out what it meant so that we could be thinking in actionable ways. But before we could think in actionable ways, we're thinking, be more present. I thought we were. We thought we were. But when asking for the grade, it's like, yeah, you're here, but you can do more. You can communicate in a different way. You can listen and acknowledge, particularly patients of color with caregivers who were coming in with notes about medications that were not working, giving the story about how patients are responding, and then wondering why they're not being believed. And what is about my skin color, my education, my command of the language, what is it? If we're partners in care, then you'll believe what I have to say because I'm the one there observing it. So all of that just sort of became foundational for thinking about what we need to do more of and be better at. So it was a melding to create this role with an intent to be consciousness, to focus on being more intense, to elevate us. I think the way David mentioned it was we want to be on a world stage when it comes to be leaders in this space of ESG. So specific examples includes what I call the adoption of Ypsilanti in a more intentional way. Yes, we've been there for a while, but clearly we could do better. The investments that we have made with regards to clinics is not the same. When you look at other places where we've made investments in other communities, it's not the same in terms of size, scope, or the comprehensiveness of services. Access to screening. Mobile mammography became a specific investment coming out of AROC and identifying community health needs in order to improve cancer screening, diagnosis, and treatment so that there would be health equity, dealing with health justice. The expansion, relocation of Ypsilanti Health Center, $35 million investment in order to improve the level of services, more comprehensive primary care, specialty care, diagnostic imaging, and community support services so that it's more convenient to address issues related to transportation so that you don't have to make 3 visits to complete one experience, which takes time, costs money for those that don't have those resources. Close to transportation, half a block from the public downtown transportation center to address that social determinant of health. Food insecurity, Million Meals Mission, which I think you all are familiar with, and thank you for your contributions. We're up to 440,000 meals, but the need is constant. My role is to make sure we keep it visible because these issues are not going away on their own. Collaboration, engaging other stakeholders in the community, government, transportation, housing, community development foundations, many, many different agencies who actually, Alfreda Rooks has done a fantastic job of shaping these partnerships. If you look at the annual report from Community Health Services, we're just taking it to a new level with the idea that U of M Health is going to be the catalyst of a conversation, and here's why. You think about a swimming pool with multiple lanes. As we talked to the different stakeholders, they told us what they were doing with social determinants of health, and yet they were doing it by themselves. We decided that it was more important to have a round table like the ones that you're sitting at, so we have all the stakeholders there to synergize, to bring it all together, to remove the swim lanes, just have one big swimming pool with the idea that we want to all get to the end together. So all of that is about what we're trying to do, engaging other stakeholders, identifying opportunities for philanthropy, to bring the business community in. And I would tell you that the mindset of those who have given money to us in the past is changing. I'll be in a room asking for monies for the pavilion, the new hospital that we're building, and a lot of times the word came back, what are you doing with health equity? Our family has changed their view in light of the murders of men that look like me, and seeing it all on television, and understanding, wow, people are being transformed. So we want to take advantage of that transformation in order to have another transformation that really deals with the root causes of these social determinants, and make a difference for the upstream influences that then affects one's health. That's a mouthful. I'll shut up now.
Thanks, Tony. I want to start by thanking Tony for stepping into this role. As Tony mentioned, for 20 years, he was a chief operating officer for University of Michigan Health. And I think the role that Tony has stepped into kind of draws on incredible experience with healthcare delivery, strategy, operations, community engagement. Tony's role as the executive director of the Michigan Health and Hospital Association Board, all of the issues that are reflected in the chief ESG officer role kind of involve all of those aspects of classic clinical care delivery, but governmental engagement, community collaboration, involvement. And Tony talked a lot about some of the important events and looking toward this role. I will go back to the Anti-Racism Oversight Committee, where the community, called the Community Subcommittee, and Alfreda's incredible work. If you haven't read the Community Health Services annual report on an annual basis, please do pick one up or read it online. But part of that was kind of both what is our relationship with communities, and then how are we thinking about what our role as a clinical enterprise or delivery system can be upstream of healthcare delivery. And one big concept in that was this notion that we were going to participate as what's in the group called the Healthcare Anchor Network, which really says as a major healthcare delivery system, we are going to look at, Tony mentioned the term, the root causes of inequities, and think about how we get upstream in areas of place-based investment, whether it's in supply chain or other areas, local hiring, diversification of our workforce, and that leadership focus in that area. So as we were thinking about aspects of our clinical delivery system, like the Ypsilanti Health Center, and the $35 million investment that was mentioned that will be opening in 2024, but having a persistent, consistent presence in upstream and bringing to clarity our role as a healthcare anchor network is important. And that is coming in, takes many steps over time. I mean, there's work being done that I've seen Tony and Alfreda and many other team in our HR teams looking at, for instance, what is compensation of our team members in different communities for our organization? What are the kind of role delineations for different team members in the different communities we serve as an organization? And starting to understand at that level of granularity, what are the factors that are driving that? And then having the leadership focus to think about levers for change, because it isn't just Michigan medicine that can drive those changes. It is, if you've seen Tony's slide of the collaboration model, around it is transportation, housing, banking. We're engaging in conversations with financial organizations about how we can stimulate more investment in many of these areas. And so, that leadership focus, and I think specific examples are kind of emerging every day, but I want to emphasize the need to bring together so many stakeholders to get upstream and how a clinical delivery system can do that. We can't, it isn't something we can do on our own, but it's something that we can catalyze and ought to be a part of. I'll say two other brief things. One is the sustainability component and what that means to health justice. I mean, David Brown has taught me a lot about talking about alignment over addition. And there are many incredible efforts happening in our organization around sustainability, but one of the questions is, how do we think about those in total? How do we measure their impact? And how do we hold ourselves accountable to progress? And I think that has been an important part of this role, building on work done by Project Green Health and actually having measured performance in this area. Just yesterday, Tony and I were in the C&W OR, where we were watching this incredible effort to actually separate the waste that you see at the beginning of operating room cases into different, simple as different colored bags that will then go to a recycling vendor rather than to the landfill. And the impact of that we're going to measure, we're going to talk about, and we're going to celebrate. And finally is the connectivity to governance. I think, at an organization level, where does the accountability, the fiduciary responsibility sit? It sits with our boards, and visibility around these issues at a board level. What are we doing to work on? Even in terms of representation in governance, from skill-based expertise to diversity of our boards, and having intentionality and discipline and purposefulness. It doesn't mean that we're perfect at a moment in time, but it means that there's that visibility and that commitment to getting better. And so I hope that gives some representation of the early work, but it is a ongoing journey in all of these areas.
If I could make just two more comments. To David's point about the governance, we have created what we call the ESG committee, and I think this will be helpful for all of you because I've created this acronym, TACT, T-A-C-T, transparency, accountability, communication, and trust. And trust, we've been talking about it as I've been listening throughout this morning since I've been here, is the key. So tying back to an earlier question about how do we build trust amongst our workforce, how do we build trust with our community, thinking about our patients, the question about learning for faculty and residents and students, going out into the community. We have lots of volunteer opportunities for people to go and see. It's not all in the classroom, that's part of it, but it's going out and seeing and listening and hearing and understanding, and folks have a growing appetite for doing that, and so we want to shape that so that the conversations that we're having, to David's point about upstream influences, we want to have conversations between providers and community before community needs a provider. So that awareness and education building becomes a part of that, so by the time that I do need a provider, we're familiar with each other. We have a relationship already built. Now we can be thinking more about partners in care and the problem in front of us, because I now have a trusting relationship that's been created by the investment we've made with time and effort beforehand.
Thank you both so much. Those were really great answers. We're going to ask just two more questions. I'd like to direct the next question to Dr. Kunkel about health equity research. We know that health equity research is a growing field. How are we at Michigan Medicine, how are we centering opportunities for health equity research as a part of our tripartite mission?
Thank you, and I'd first like to thank you for monitoring this session, and thank Dr. Brown for inviting me to be a part of this. Often research isn't thought of as being part of the DEI, but we have a voice at this table, and I'm thankful for being able to offer that. So again, going back to our strategic plan that we developed, and I'd like to keep mentioning our strategic plan because it's one mechanism that we can actually set up funding streams to support different efforts. So one of our strategies is to create communities of scholars, and we've done that successfully in other areas. If you look at cardiovascular, diabetes, a number of other areas that have historically been invested in here. But we, again, had workshops and symposiums working with our faculty, learners, and staff to identify what other areas need to be invested in. And what we came up with, we need to continue to invest in neuroscience, and we need to continue to invest in a leading new area, artificial intelligence. Inflammation was another one, opioid and pain. And the fifth one that was unanimously decided to invest in was health equities. And what we've done with regard to health equities is to invest in behavioral science, community-based science, and implementation science. And the latter is, how do we drive science into the community? And I'd like to give you one example with that, is that we've set up a system called Patients as Partners Academy. We wanted to look at our patients out in the community, not to work on them, but to work with them. They have a lot to say. They need to participate in these studies, and we've reached out to them significantly. The areas that we are going to invest in initially is into women's and children's health equities, but there are many others that will likely be on the docket. Another area that we continue to invest in lockstep with acquiring our affiliates across the state of Michigan, is to make sure that research is there to support those individuals there that want to do science, especially research into clinical areas and clinical trials. And again, we've landed on health equities with our affiliates to make sure that we do offer our expertise to work in lockstep with them to conduct the research at our affiliates. And we have a number of workshops coming up. I'll give a shout out to our Associate Dean, Julie Lemang, who is the PI of our CTSA, which is embedded in the Michigan Institute for Clinical and Health Research. She works tirelessly on health equity issues, being a pediatrician herself and understanding a lot of what needs to be done in that realm. We have a number of workshops coming up, how to take implementation science to the next level, and as I mentioned before, to engage our affiliates and our patients around the state of Michigan. So again, thank you very much.
Thank you. We're going to transition in a moment to questions, our Q&A from the audience. I just had one last question for each of our panelists. We're all here today because we care and we want to see things change for the better. If each of you could just give one quick line, sentence, a recommendation or an ask to all of us as to how we can move that needle, what would you recommend? Just one thought from each of you.
Easy, I got it. No, it's easy. We've got two base measures that are equity focused, pediatric influenza and adult blood pressure. It's because there are real gaps, and it's because we know how to close them. And so it makes me furious, and it should make you furious, that we vaccinate our children of color at a rate of 15% less than the CDC average for this country. In our our University of Michigan pediatric primary care patients, our patients that identify us as their doctor, we are vaccinating for flu at a 15% lower rate than the national benchmark, and that is fixable. So that pediatric flu and adult blood pressure, if you aren't aware of the measures, there's a lot out there, and happy to talk more about it.
If I could jump in and have an extension of that, is to help us bat down the anti-science attitude that's coming across our country. We could be in big trouble when the people that are voting for people into our office don't believe in vaccinations, don't believe in science. All I have to tell you is go back home, look at everything from the electricity running through your house to the instrumentation that you have to the cars that are now being driven by computers. Science counts, science matters. But biomedical science needs to have advocates, and it needs all of us to be advocates. And I would welcome any help that any of you could give.
Help us diversify the community of caregivers, and not just clinicians, but all caregivers, because we know there's data that doing that will help improve the outcomes of society's health.
One fundamental component of the belonging and inclusion component to me is paying forward time, experience, expertise, and opportunities. So everyone here is a leader in our organization. Reach out to colleagues, spend time sharing opportunities and challenges in the organization, provide sponsorship, mentorship, and help elevate the change in the organization that we're looking for.
My one sentence, I guess, is advocate, advocate, advocate. Speak up for doing the right thing. I was in a conversation with a legislator last year, and he shared with me that he couldn't say equity in Congress anymore because he was getting a backlash. I brought that to the attention of a leading industry executive, and the response was, no, we do need to figure out how to stay in our swim lane. I said, well, you know what? I don't believe that. And actually, I don't swim that well. So I'm not going to stay in my... So get out of your lane. Don't let any boundaries keep you from speaking up and advocating for the right thing.
In medicine and healthcare, there are so many long traditions and so many ways that we do things just because. Even as a surgeon, I learned that we did things and I didn't understand why, but we perpetuate that and continue those things. So I would say, just as, you know, sometimes we drive to work and we don't pay attention, we just get from point A to point B. I want us to pay more attention and to question, you know, why are we doing these things this way? Does it have to be this way? Is it fair? Is it just? And just because we went through it and were quiet doesn't mean that we have to continue to be quiet. So I would say question, speak up, and challenge in a professional way.
Thank you. And now we'll take some questions from the audience.
So for the questions that have been submitted, there are 2 questions, so bear with me while I combine them, about artificial intelligence. And so we know that data and calculators, as has been mentioned today, that we have bias, and so when we create things like AI, that bias is embedded in these systems. And so ahead of the introduction of generative AI and AI in general, what are we doing as University of Michigan Medicine to address potential concerns of using AI and to reduce bias so that we don't have that when we're using artificial intelligence?
So I guess I'll take that one to start. That's a great question. It is, as David said. Artificial intelligence is a double-edged sword. It's coming down the pike like a freight train. It's going to be embedded in the next few years into everything we do, especially in medicine. A lot of the data that we have is being used to generate those algorithms that will interrogate Epic to determine whether you need your next treatment changed. But we have to make sure, as you said, that we control this. So we do have some individuals here at the university who are very interested, have an international footprint in the ethical use of AI. These individuals are trying to make sure that the right policies get addressed, and these policies need to be instituted ASAP with regards to making sure that what goes forward is equitable and ethical. So we do have investigators here that aren't just using AI to develop the next algorithm to address a problem. They're studying AI from the standpoint of how do we keep it on the straight and narrow and a usable entity for us.
And maybe I'll just provide an imperfect comment on that. I think probably in March I was out and I would on occasion listen to like a podcast, and this was about like you have to bring AI, generative AI into the workplace, right? It's gonna fundamentally change the lives of employees because it takes a lot of the things we do every day and makes them easier. And we're all feeling at the limits of our bandwidth, and so where do we start to apply it? And there have been great ideas in, for instance, reducing administrative burden for our clinical colleagues, like the in-basket, right? Are there messages that come in through the in-basket that would lend themselves to an AI response? Are there even some of the work we do in the organization? I get asked this all the time, how are you using artificial intelligence to create efficiencies in the delivery system? And so with the enthusiasm to implement comes the consideration of unintended consequences, and I think this is one. And so what it speaks to me is something I think we have an opportunity to do well here, which is to kind of have a governance and an evaluative element of this AI when implemented. While the intended consequences might be visible, how do we contemplate what the unintended consequences will, and have some sort of governance or oversight structure to make sure we're not going in a direction of the exact opposite that we wanted to. So some of it is how you create structure for implementation, even with the enthusiasm, that exists. Thank you.
Another question I would like to ask is related to employee and staff satisfaction. Dr. Miller, you noted that we are looking at employee engagement data, which reflects on our patient care. So how are we addressing burnout, workload, and fatigue on a structural level?
I will say that, that's such an important question. And, when a point of pride, if I might, was that between 2022 and 2023, we did see improvement in our staff engagement. I think we went from around the 35th percentile to around the 63rd percentile. Now, we would all like to be at the very highest level, but there was a lot of focus on communication, well-being, respect. I think visibility, and to David Brown's point, a variant of that is curiosity and understanding and learning about how we can make an organization better, and then actually implementing some of those changes. So that kind of visible culture in our organization is important, but specificity around the issues of well-being and burnout. So what are some steps that we're taking, for instance, to reduce administrative burden? Well, from a clinical perspective, I think there are a number of initiatives underway to reduce, for instance, in-basket burden. Amy Cohn from the College of Engineering has done a pilot with our centralized nurse triage that has reduced the number of what I'll call automatic messages that go from our centralized nurse triage program to our primary care physician. So when they open their inbox, there isn't there's a reduction. It hasn't fixed it to any of our primary care colleagues who are here listening. We understand that we haven't fixed it, but these are specific steps that are being taken. I think there are other elements of this that relate to how do we create greater opportunities for local decision making in the clinical enterprise. And I think we are a big complex organization where everything can't be completely decentralized, but I think creating a framework and listening and allowing decision making to occur locally is something that we're working hard at. I don't say that we have the solution, but we're looking at the way our teams work together. We're looking at how resource decision allocations are made and trying to create a bit more agency in local settings that I think has an implications for wellness. And then I think, just doing some things differently and saying, do we really have to do that? I'll give an example. There's a regulatory effort that Deb is aware of. Deb was on this call that we've been told we absolutely must do this, and we're starting to question some of those things. Do we have to do this right now in the context that everything's going on with our team members? So I think those are some elements of that, which is really a fundamental question in our organization right now, which is how do we recognize all the changes and all that we've been through and reduce some of the things that we don't see are value added to our goals of education, research, clinical care, community engagement.
Thank you. That was a great answer, and I'm just going to add to it that we do have a change in the role. We have a chief wellness officer who is coming on board November 1st with responsibility across Michigan Medicine. So it's not just a primary focus on faculty or another role group, it's across. And that person will be at the table for more of the discussions where decisions are made that impact wellness, looking through that wellness lens. It's not going to be an overnight change that everyone's going to wake up the next day and say, wow, things have changed. But that, I think, is an important step toward putting energy and resources behind many of the projects, some of which David mentioned, and following through and making sure that we're on the right track or changing direction if we're not.
Thank you. And last question I'll ask that I think is very important is about retaliation. And so Dr. Pleasant referenced earlier about how her and a resident spoke up because a patient wasn't receiving adequate care for pain. And so when we have people who are speaking up for equity concerns, how are we ensuring that they don't face retaliation? And as Dr. Brown mentioned, we know that there are still some of those structures in place, what power that folks have at Michigan Medicine. So what are we doing to ensure that when folks speak up, that they don't experience retaliation?
I'll start. So sometimes there's retaliation, and many times there's a fear of retaliation. And so we have to figure out how to untangle those two things. And the answer is actually sitting right next to you, Ashley, because Sonia Jacobs and others have created a training, an anti-retaliation training program for leaders so that they can understand how their staff are feeling and be able to kind of address them and to be able to approach them so that there's not that fear or real retaliation. Again, it gets back to timing, what David Miller just said. It's hard to make everything a mandatory, but that is one of the things that we have to get on the docket so that our leaders are equipped and understanding. I did the original pilot of the training, and it was incredible and eye-opening, and so it really changed even how I approach my team and others. And I don't feel that I'm retaliatory, but I think that you can sense that at times being a staff member, especially with the power differential. So hopefully we'll be able to roll out that training in the future for Michigan Medicine.
I think that we have to acknowledge that folks are human. And you said, how can we ensure that there won't be retaliation? We cannot ensure. We can provide the culture, the framework, the teaching, but there are some disbelievers. When you talk about equity, some would suggest that things are just fine. And we would say, well, the reason we're talking about equity is because there's inequity. Equity is an improvement, it's part of the journey. And so if there are issues or concerns about retaliating for speaking up for the right thing, there are resources that are there for people to go to try to self-correct. But at the same time, we coach to our culture. But if folks don't want to be a part of the culture, then we have a responsibility as leaders to help them find a new place to be.
I always say that just a tagline behind that, thank you, Tony, is that, you know, everyone talks about being on the bus if you want to be on the bus. I always say there's a bus for everyone, and we can supply you a transfer.
Thank you to all our panelists. If we can give our panelists and our moderator a round of applause. Thank you all so much.
We're going to take a picture?
Oh, yeah, we're going to get your picture on the side.
Okay, thank you. We're going to stay together for a picture on the side. Okay.
Yep, just hold it. So we've made it to lunch. And so before folks move, we will have a tabling session during the lunch hour. So that will be down the hall. And so I want to allow the folks who are at the tabling sessions who will be working those to please exit the room now. And we'll give them a chance to move down the hall. And those tables will be for you to learn more opportunities about additional opportunities for collaboration. So those folks will move down. Also, don't mind while we get a picture of the panelists, and then we'll begin serving lunch in just a second. So if the speakers and presenters from this morning, if you all could go ahead and start eating, and we have 2 buffet lines, please go ahead.
Hello. I just want to say one more thank you from our team for joining us, and then remind you as you're finishing up your meal that our resource groups are down the hall in the concourse for a tabling session. Thank you.
Thank you all. I hope you all enjoyed lunch and enjoyed the conversations. And so we're going to go ahead and begin our afternoon sessions. And so the first session of the afternoon, I would like to invite the Student Diversity Council for Serena Bidwell and Sanaya Arani to come to the stage, and they'll be presenting about what work is happening in the student space. So we're happy to hear from them.
All right, good afternoon, everyone. Thanks so much for hanging around after lunch. My name is Serena Bidwell. I'm a fourth-year medical student, and I am the past chair of Student Diversity Council.
Hi, everyone. My name is Sanaya Irani, and I just completed my third-year medical school, and I'm getting my M.H.A right now. And I'm the current chair of the Student Diversity Council. Thank you all for being here. Thank you for being here, and we will dive into our presentation about the Student Diversity Council, some of our initiatives, as well as other student initiatives and ways that faculty and staff can get involved. All right, so our agenda for this presentation, we will start by giving you a short background on the Student Diversity Council and how it came to be, and then we will talk about our different pillars, which include the Education Committee, the Activism Committee, the Outreach Committee, and then lastly, we will close with ways that faculty and staff at the University of Michigan Medical School can get involved. And so just a couple years ago, we decided to revamp the Student Diversity Council after the extrajudicial killing of George Floyd, to center on the pillars of education, outreach, and activism, with the primary goal to amplify underrepresented student voices in medicine and to facilitate spaces to process traumatic events that occur locally and internationally. And so now our structure of the council is the three pillars that we described: the Education Committee, the Activism Committee, and then the Outreach Committee. Each of the committees has multiple committee members and is overseen by a vice chair. And then the vice chairs are overseen by a chair, and we all work together to work on different initiatives that are related to the student body and to respond to any inquiries from the student body as well.
All right, so the first committee that we'll be talking about is the Education Committee. And as you can see in this figure, the schematic shows just the first year curriculum. The big blue boxes represent the scientific trunk, and then everything running below is the co-curricular parts of our curriculum. And as you can see, that means there's a lot of opportunities to intervene and make a difference in our educational path. So one of the main projects that we undertook was a comprehensive review of the entire M1 curriculum, specifically looking at lectures for the language and bias. We also looked for places where lecturers could include more diverse perspectives. So one example of this was for our dermatology lectures, making sure that they're showing pathology across a range of skin types, rather than historically a lot of the lectures have been taught with just white skin, which makes it actually very challenging in clinical spaces to think about what these conditions might look like across a variety of patients. Additionally, we looked for topics that might be potentially triggering for students and reminded faculty to provide spaces to debrief after these experiences, and also provided language to help start the lectures to get students in an appropriate headspace and just remind them that it's okay if they're feeling different emotions in reaction to the material, but that the faculty are really there to be supportive of them. We also have patient panels that occur throughout our curriculum, and a lot of these panels have involved long-standing relationships between the patients and the faculty. So year after year, it will be the same patients on the panel, which is fine, except for the fact that a lot of the patients do not represent the diversity of our community. And so we've been advocating to invite new patients to the panel and to also think about how we're representing the different perspectives of our community in those panels. And in addition to that, we created a secondary panel through a collaboration with the Office of Patient Experience to bring in patients who are specifically talking about how social determinants of health impact their experience as a patient. Additionally, we created the Health Disparities Curriculum that runs alongside of our clerkship or our second year of medical school. These lectures are really focused on topics related to diversity, equity, inclusion, accessibility, and justice within a certain specialty. So you can see example slides, the title slide from the ENT lecture, and then a slide from the PM&R department's lecture. Most recently, we've also implemented a note-taking event. This is primarily led by our emergency department. I actually recently finished my emergency medicine clerkship, and we started off our orientation with a lesson about the language that we use in our patient and medical documentation. So one example of this is describing a patient as a frequent flyer in the emergency department immediately puts bias in the minds of the providers. So there are ways that we can use more neutral language and think about the words that we actually put into our legal documentation and how that immediately paints a picture of the patient that we're talking about. We also recently held a hidden curriculum event in which several faculty and residents came to talk about ways that students can be successful on the clerkships. These are things that maybe don't show up on the orientation slides about the rotation, but things about how the evaluators are looking at students and what they're looking for specifically when they're grading.
All right, now I'll chat a little bit about some of the ongoing and past initiatives through the Activism Committee. I was fortunate to be on the committee for the last couple of years, and I was the vice chair of the committee last year, so I've been directly involved with some of these initiatives. One of the initiatives that we put forth to the deans and administration a couple years ago was the trauma protocol. This was something that was modeled after UCSF's trauma protocol, and aspects of this have been incorporated into the way we address things here. And so the reason that the trauma protocol was created by the Student Diversity Council and shared with faculty and administration was because we wanted to provide kind of space for students in light of local and national, international traumas, considering that students have a very busy course load and sometimes don't have the time and space to process certain events. So we wanted to acknowledge that. And so the protocol was created with 3 different levels: the level maize, level blue, and then level Wolverine. Level maize addresses events that affect like a small portion of students personally, so those could be like natural disasters or family events. And then level blue are national and international events that affect like a majority of minority students and their allies. And then level Wolverine are events that affect a majority of students. And so some responses that we shared with administration that we felt the student body would respond well to were school-wide emails that include relevant resources, brave and safe spaces that are created in response to these events, as well as extensions in the preclinical and clinical space that may include a day or two for students to submit assignments later, or wellness days that students can take as needed. So this was one initiative that we worked on a couple years ago. And then another initiative that we started working on last year and received a lot of support from the Teener Family Fund, and we're very grateful to them this year, was the Moving Stipend Initiative. This initiative was put forth by one of our first-year students that was on the Student Diversity Council. She stated that last year herself and a lot of classmates had a lot of difficulty in the transition financially from coming from their homes in different states to medical school at University of Michigan. And we reached out to Carmen Colby, who's the director of financial aid, and we learned that a lot of moving costs are not actually included in financial aid packages because they occur prior to the start of medical school. And so this was a gap that we were able to fill with the stipend. And so specifically, we were looking to fund students to help them with costs around moving that would include security deposits or buying certain furniture or things like that. And so this year we were able to raise a good deal of money, thankful to all of our donors, and the fund has now been made into an endowment, and so we're hoping to continue raising money over the years. And this year we were able to afford 4 students the full amount that they requested, and so we gave out $5,750 across 4 students. And the way the awards were determined is that the financial aid office has a needs metric that they calculate for students that apply. And so based off that, we gave the students that had the greatest need from that metric the full amount that they requested this year. And we hope to continue doing this every year. Another award that was created by one of our alumni, Dr. Brandon Ellsworth, was the Residency Transition Award. This is similar to the moving stipend, and it aims to fill the gap between graduation from medical school to and the move to residency. And so he had a donor that he was in contact with who wanted to donate money around this cause. And so every year, the Student Diversity Council awards students from low-income backgrounds that need assistance with the transition to residency $1,000. And these awards are processed after financial aid disbursements are complete in order to not affect their packages. And then the last thing I'd like to share from the activism committee is that we have been working closely with the First and Family group at the university to gather some data in terms of transportation struggles that students might have at the university. As many of you might know, the university expects students to have access to a vehicle by the second year of medical school, as we need to commute to clerkships all around Ann Arbor and Ypsilanti. And so we wanted to just raise some awareness around some stats that we found from this survey. And we're hoping to turn this into kind of some promotional work that we can use to reach out to any interested donors. And so as you can see from this graph, students paid or received access to a car from a variety of different ways. From the students that did pay for their own vehicle, we found that about 36.8% of respondents spent over $10,000 on their vehicle, and then 15.9% of respondents used federal loans to pay for their car. Some other points that came up through this survey is that about 18% of students that responded to the survey did not have somebody to rely on during a financial emergency. So that could be physical support or financial support. And then when we looked at this further, there was a breakdown across race. And so as you can see, as compared to 14.96% of white student responses, who felt they did not have someone to rely on for support, we found that there were greater percentages across API students, Black students, Latinx students, and Middle Eastern students. And so a quote by one of the students in this survey kind of paints this in a better light. In terms of transportation, they stated that, "I believe one could survive on public transportation alone, but it would be a significant disadvantage compared to their more affluent peers who have access to a vehicle and parking, and this inequity should be addressed by the medical school." So thank you. These are just some of the initiatives that the Activism Committee has been working on over the last couple of years, and now I'll turn it back to Serena to talk about the Outreach Committee.
So the Outreach Committee was actually where I started with Student Diversity Council, and my first big project was helping to kind of revamp our M.H.A.'s mentorship program. So M.H.A. stands for the Michigan Faculty and Medical Student Program. The goal is to really partner with incoming first-year medical students and faculty to create mentorship pairs that meet regularly throughout their first year. And we really found that there was a gap in first-year students with connecting with faculty, since a lot of the first-year curriculum is outside of the hospital. We have quarterly emails that we send to both the mentor and mentee with different discussion topics, questions that they can answer together, and really focusing on things related to DEI that they might find in a clinical setting. Additionally, we have one annual in-person event per year to bring everyone together and to kind of celebrate the year of community building. One M.H.A. student commented in one of our surveys saying, "M.H.A.s gave me access to early mentors who provided me with research and shadowing opportunities as an M1." Additionally, one of our key initiatives through the Outreach Committee is our wellness mini grants. So these occur in funding cycles once or twice a year. And the grants are small, only about $25, but we try to give them to as many students. And the students will submit a very short application explaining how they will use the money if they receive it, and then it's reviewed by a team of SDC members using a standardized rubric. You can see some of the items that we funded, everything from therapy appointments, groceries, happy lights for the winter, and even exercise classes to help if you're looking for ways to stay active outside of the school gyms. And we also want to acknowledge that SDC is not alone in this work. We are one organization at the medical school, but there are many, many others. There are several identity-based student groups, along with different groups based on kind of the pathway that students have taken to medical school. For instance, Winding Roads is for students who have been maybe on a more non-traditional path or who have been career switchers and then come to medical school. Additionally, we have a whole bunch of activities, things related to learning different languages in medical school, both global and domestic research opportunities, ways to serve underserved communities through our various clinics that students are often largely supporting. So we just want to say that while we're here kind of talking about the work of one organization, we're really not in this alone. And then if you're wondering how you could be involved in some of the initiatives, we're always looking for faculty mentors to serve on our MFAMS program. So that happens, usually we recruit kind of end of summer, early fall for those mentors. You heard about a lot of different funding initiatives that we have, and so a few times a year, especially like Giving Blue Day, you'll see email pushes from our org, and all of the money that we raise goes directly back into students through these different activities. So that's another way to be involved. If you're an educator, you can really think about what you're showing to your learners and how you're thinking about the diverse patient perspectives when you're meeting with learners and when you're making lecture slides or preparing educational materials. And then lastly, we just hope that everyone in the room really understands the medical school journey and both the challenges that students may face, especially from various different backgrounds, whether that's financial challenges, academic challenges, different situations that may come with them to medical school. We are human as well as medical students, and when we bring all those human parts of us with us throughout our medical school journey. Lastly, we just want to say thank you to our team. We have an excellent group of faculty and staff advisors, along with the entire OHA department who really supports us. And we provided our contact information if anyone wants to follow up with questions. We would be happy to hear from you.
Thank you so much. So if we can give Serena and Sanaya another round of applause. So I'm actually kind of glad to get to this part of the symposium so that I'm not back and forth to my seat. So I'll be up here for a minute. My name is Ashley Wilson. I am a program manager in the Office for Health Equity and Inclusion. And so I'm excited to talk to you all about our DEI leads and relaunching our DEI leads at Michigan Medicine. And so when we think about our DEI leads, I want to talk about that we are relaunching these. So these are not new folks we're adding this to Michigan Medicine. This is an existing framework, and I'll give a bit of history and talk about where they originated, but then also talking about what we want to do moving forward. So we've referenced and talked about DEI 1.0. So I just want to give a little bit of history because I think that's helpful to think about where DEI leads came from. So during DEI 1.0, that was from 2016 through 2021. And so there were two committees that were commissioned by university leadership. Those two committees were created, and subsequently they found that there's a strong need for cultural competency and a more inclusive campus environment. From those recommendations, that's how we got to the DEI 1.0 plan. So diversity, equity, and inclusion, our overall strategy for implementing diversity, equity, and inclusion. In DEI 1.0, the whole goal was for all of us to do something related to DE&I. We have this need for everyone to do something, to be supportive of inclusive scholarship and teaching, developing a diverse community, and also an inclusive and equitable environment. And so the key initiatives under DEI 1.0 were identifying resources and accountability, and then ownership belongs to all of us. Like I mentioned, we all need to do something. It's not just the work of certain people. No, all of us are included in this. And so when we think about what we've done during DEI 1.0 and thinking about Michigan medicine, so there are over 150 DEI leads that are champions of innovation and change. And so with our DEI leads, we replicated this structure from the Office of Diversity, Equity, and Inclusion on the campus side. During DEI 1.0, they created these DEI leads because they're like, we're such a large organization. How are we going to make sure that this message of diversity, equity, and inclusion really infiltrates and gets to all parts of University of Michigan? And so us at M.H.A, we replicated that structure knowing that the academic medical center is very complex. And so the same thing to make sure that this message of diversity, equity, and inclusion goes throughout our academic medical center. So DEI leads, they represent a variety of departments and units. Also, their work throughout DEI 1.0 has included new initiatives that foster community and connectedness amongst employees. Also, they have just been innovative in bringing new ideas. And what I find most valuable from our DEI leads is that they push us as an organization to be inclusive and always to challenge the policies and procedures that we have. And so I would like to thank folks. So now that I am a part of the DEI Leads program and hoping to support this structure, I definitely have to give a shout out to LaTanya Berry-Hill, who's in the back, and also Clarissa Love, who have helped to guide DEI and the DEI Leads during DEI 1.0. Also, I would like to give a special thank you to all of the current and former DEI Leads. If we can give them all a round of applause. So in DEI 2.0, as I mentioned during DEI 1.0, the goal was for everyone to do something. In DEI 2.0, we want to be more strategic about the work that we're doing. We want folks to focus on DEI work based on their work area in your niche. So what can you do based on your body of work to advance diversity, equity, and inclusion? So we don't need everyone to be a facilitator. Shout out to Blair Tinker, who's our lovely facilitator in M.H.A. She has that job, she holds us down. And so we need folks to focus on what can you do that is instrumental to your work to help advance diversity, equity, and inclusion. And we've been traveling this road, this health equity roadmap. And so for both employee resource groups and for diversity, equity, and inclusion implementation leads, they fall under the systemic and shared accountability lever. And so in this lever, you can see for equity influencers, which are the DEI leads, we're right in the middle of immersing. And so we want to move towards affirming and transforming. And so as Kristen Howard mentioned earlier, this really gives us a snapshot of where we are with the different levers in the work that we're doing, and really helps give us a grade so we can know what we need to do to move forward. And so in this immersing phase, it really included strategic planning and the work that we were doing, and then early implementation. Now we want to move to making sure that DEI leads and the support and infrastructure are really embedded in Michigan medicine to support these DEI leads and to make sure that their work continues in perpetuity. With the revitalization of the DEI lead structure for 2.0, we really want to identify and confirm representation from segments and units for DEI leads. Also, we want to operationalize DEI leads to have support from M.H.A, also from their leaders and their peers. So as this occurs and continuing as we move forward, we want to affirm and transform the process and positions to make sure that our DEI leads have the support they need and also the power to really make change in their units and their departments. And so I want to talk about 5 key areas that we think are crucial for our DEI leads to continue to be able to do the best work and to advocate for diversity, equity, and inclusion. And so those 5 things are communication, professional development opportunities, support structures, accountability, and representation. So we want to make sure that over these next 5 years, and we've spent time strategic planning for DEI leads. We think it's critical to understand that DEI leads, in order for them to be successful, that we must support and buy-in is crucial from everyone at Michigan, including our senior leadership, also the direct supervisors and the DEI leads themselves. And so the role for DEI leads, it is theirs themselves. So everyone has to define that role for themselves. However, we have to succeed. It's a part of all of us supporting the work. And so I'll next go through these 5 crucial areas and what does that look like for DI leads moving into this relaunch. So when we think about communication, this is really to serve that communication is really a highway. And so when we think about this communication, there's many levels of communication. So we have the Office of the President at University of Michigan. So they're setting the strategic guide and the framework for everyone at University of Michigan. OHA, we work with the Office for Diversity, Equity, and Inclusion, and so they pass information down to us. And we are really the connector from campus to the Michigan medicine community. So once we receive information from them, we pass it to the Michigan medicine leads, which we hope and they pass along to their departments and units. So this just really demonstrates that it's very complex and we have this flow of information. So communication is really critical. And so, OHA, we communicate broadly about health equity and diversity, equity, and inclusion initiatives. And we really want to be able to create a group of folks, not only DI leads, to get this message across. So moving forward with our communication plan, it includes DI leads, also DI associate chairs, so on the faculty side, our resource group leaders, folks who are interested and supporters of this work, to really disseminate these messages. And so we want to make sure that we have those opportunities to share that with everyone. Also, when we have thinking about direct communication that we need to inform DEI 2.0, with the direct communication, we need DEI leads to communicate back to us about the work that they are doing. We need to know for reporting reasons, and also we want to make sure that we are in alignment and that we are following our strategic plan. And so we want the unit to be able to require that DI leads are either that are at least a year into their roles and also are at a level, a seniority level, where they can really affect change. Also, very importantly with communication, departments and units are going to be required to provide frequent opportunities for DI leads to speak with leadership. It's important to be a part of those conversations and for the DI lead voice to be a part of the conversations where decisions are being made. And so really, communication will be crucial in a variety of ways of thinking about these DI leads when we're communicating from OHA to DI leads and vice versa. When we think about professional development, DI leads do a great amount of work, and we want to provide DI leads with something. And so we want to provide opportunities for them to grow and develop in their roles and also in their careers. So when we think about DI leads, we are going to provide quarterly trainings, we meaning OHA. We're going to provide at least quarterly trainings to support their efforts and what they want to do when it comes to their professional development. So we are seeking from units and departments to have protected time for DI leads quarterly to attend these trainings. And most recently, we have already begun implementing some of these professional development opportunities, some of which have included the logic model session that we had during the summer. Also, you all will get an email from me, current DI leads, next week about an opportunity on November 1st from CRLT. That office is putting on a workshop. Additionally, we were able to help fund some of our DI leads to attend the Women of Color Task Force Career Conference. And so we recognize that it's very important to have opportunities to explore other DI topics and also within your careers. So we are really seeking this commitment from units and departments, and also we are committing ourselves to providing these opportunities for professional development. When we think about support, so this work isn't easy. We know that. If you do any type of DI work, we all need support, and we've talked about a lot of the collaboration that has gone into this work today. And so for our DEI leads, we, OHA, are committing to providing that support. And so the support includes, during our meetings, to empower and support DEI leads to make change based on their body of work. Also, it includes hosting DEI lead meetings so that DEI leads can collaborate with one another. And again, that alignment over addition, to pool resources and energy so that we can work together. Also, we'll provide opportunities and provide a clear vision for the work of DEI leads, so it's no guessing what we're doing. And also, we'll provide consultation and a clear framework about how we are moving forward. And with DI leads, we'll make sure that they have access to all needed material and data. That's very important. We gotta have that data to say the work that we are doing, that this works. We're not just doing it to do it. And so we'll provide DI leads with any support they deem necessary. So I know this list might not be exhaustive. There might be other things that DI leads need that come up, and we are more than willing to meet those needs. And when we think of accountability, we're talking about accountability for all of us, so not just for DI leads. And when we're thinking about this accountability, OHA is committed to DI leads through confirming their support and representation from units and departments. Also, we'll monitor and have the annual DI lead agreement, which outlines the responsibilities for DI leads, OHA, and the unit and department, so you all can also hold us accountable. We'll provide those quarterly trainings. Also, it's very important, we want units to provide protected time for our DI leads. We know that a lot of DI leads are doing this work on top of their typical job, and so they're doing it outside the hours. We want protected time, so we don't want to overburden folks, and we know that fatigue and workload has been the #1 priority. So we want to take that into account when we're working with our DI leads. As I mentioned, we want to have that regular cadence of meeting with leadership, which we think is very important for our DI leads to be in these spheres of influence because they know the work that is happening, and so we want to make sure that their voices are heard. When we think of representation, so this is the big thing that we're working on right now, representation. We know we need everyone at Michigan Medicine to be communicating with OHA. We know we need everyone to communicate with us because we need to know what's going on. We don't want it to be instances where, as Kristen mentioned, like, oh, we should do this program, and someone else was already doing a similar program, right? So we need to be able to collaborate with one another and know what all is going on so we can put people in the same room to collaborate with each other. So right now with our representation, we are seeking to confirm the number of DI leads and the representation, also looking at our structure overall at Michigan Medicine, thinking about reporting and how people report up. Are there duplicates in representation? Are we missing some folks who don't have representation? So that's the current process that we're identifying right now. And so over the next 5 years, we really want to make sure that this year that we have the reporting and the representation correct so that over the next 5 years, we know the DI leads and the units and departments we're working with. We know who we're supporting, and they know who to come to for support. We're following the recommendations of our campus partners, the Office for Diversity, Equity, and Inclusion. They are champions of this work, and also they really serve as a national exemplar for this work, so we're just gonna cheat off them, and we don't need to look anywhere else, so we're gonna just take that and really help infuse it and bring it to Michigan Medicine. As we know, as a large matrix organization, we need structural approaches to create change. And so we really want to work with our DI leads to help ensure that we are executing the Michigan Medicine DI 2.0 plan, and also that we're really making change. And so next steps. So for the current DI leads, you all will be receiving a survey from me. And so this survey, again, it's important for us to identify representation. And so with this representation, we will be providing a survey, quick 7 questions that is trying to get at the representation, and also we want to know about funding for DEI. We know we can't do much if we don't got no money to do it. So we want to be able to know what are our DEI budgets, what do we lack, what do we need. So we want to have that as a part of the survey. So this survey, again, short 7 questions. It will go out to DI leads as well as unit and department leadership so we can get those responses. Once we have those responses back, we will confirm our structure and support for DI leads and representation. And then we're planning for early launch of the relaunch of the DI leads in early 2024. And so we're asking DI leads, you all will get another email from me. Sorry to spam you with emails. You all will get another email from me in November asking you all to contribute to the Health Equity Roadmap. And so that is what I have on DI leads. Of course, I'll still be here today, so always feel free to come up and we can talk about it. Next, I would like to invite Callie Mae Lake to the stage, and she will discuss the relaunch and reintroduction of employee resource groups.
Thank you, Ashley. Let me see if I can get this. Oh, how's everybody doing? It's after lunch, and I get to be the last, and that's exciting because everybody's got a foundational knowledge of what I'm going to share with you, but also it's also an honor to be a part of this presentation and this day. So thank you all for having me to be a part of this, and I'm excited to share with you all the new resource group restructure, or the new structure. You'll hear it relaunch, so I'll share with you what that looks like. But before I get started, I really wanted to talk a little bit about the background and how we got to where we are today. So DEI 1.0, you've heard a lot about that. The resource groups at that time were operating as a feedback mechanism to leadership and as a foundation for developing community and belonging. Then we had a pandemic. And the ability and the capability and the capacity to support the resource groups was stretched thin, just like among the nation and here across Michigan medicine. And yet through all that, the resource groups, they continued to meet the need for the community during a pandemic, and they have continued to be a valuable means of relating and belonging for our faculty, staff, and learners here at Michigan Medicine. And what they did really gave us the foundation of best practices to lean into, to live into. And so then O.H.A. said, how can we offer better support? So there were focus groups last year, and we listened to those resource group leaders, and we listened to those members. And now using that feedback, we have stepped into a new commitment with more capacity now to create space and community for these vital groups to grow and have impact here at Michigan Medicine. So you've seen these levers or strategic objectives, which is great. We know how many different ways that we need to hear something before it really sets in. So I'm glad to share with you once more. A part of the new commitment that O.H.A. has, verbalized and written in stone is that resource groups now have been included into Michigan Medicine's DEI 2.0 strategic plan under the strategic objective of systemic and shared accountability. That strategic objective is defined as creating infrastructure to maintain accountability and to sustain the DEI work across departments and service lines. Specifically, that commitment is written in the plan to show that we will empower and support our Michigan Medicine community through identity-based groups, and they will be empowered to heighten awareness of issues affecting all of our community. Some of the planned actions that we have explicitly written in that plan are to develop and implement a sustainable structure. Right now we've developed a toolkit and we're getting feedback from our resource group leaders to have the sustainable structure, to have continuity year over year. Develop and socialize and implement that plan. Support our resource groups in marketing efforts as well, including event promotion, membership campaigns. So in the next few months, you'll see some things coming out on headlines. We'll work with them on membership growth. Also creating a program coordinator, a position to provide more support for our resource groups. My position now, I'm the point of contact for support for the resource groups within O.H.A. And as we anticipate there being growth over the next 5 years, we also want to add in that additional support. And we're going to be looking at these planned actions with outcomes and metrics in mind. And we're, numbers of resource groups that have confirmed charters. We're going to be looking at total leadership positions that are confirmed. And we're looking at a year 2 goal of each resource group having 50 members. And what other ways than those outcomes and metrics can we track our progress? And you've seen this a few times now, but we are, under that strategic objective, we're in the leadership accountability in the immersing phase. I wanted to give a couple examples of where we're at now and what we can be, how we can get to the next affirming stage. So an example of immersing for resource groups, specifically from the AHA website, is that hospitals internalize DEI task force that create a strategic plan with a focus on resource groups. And so to get to the affirming stage is that employee-led groups conduct regular assessments of their progress, but also that the hospital launches employee resource groups that have executive sponsors, and that there's an operational budget associated with those resource groups. We don't have a budget right now for resource groups, but I say that because if you continue to say it, the budget will come. That's it. If you build it, they will come. So then, if we pull back, so that's our 5-year plan. That's the next 5 years. But if we pull back a little bit, what's happening now, what's happening in year 1, infrastructure for efficiency. That means, and you heard it from Ashley too, clarification, communication, and consistency. So there's multiple roles, as Ashley stated, that are supporting DEI work, and OHA, needs to communicate consistently with all parties. We need to help define those roles, which we're doing right now with the resource groups. And then we are going to serve as a resource convener and provide structure and strategic partnership through this process. And for me, when I think about working and supporting the resource groups, I always go back to what guides us. What is it that guides us here? So at the University of Michigan, we are committed to pursuing deliberate efforts to ensure that our campus is a place where differences are welcomed. And we know that by building critical mass of diverse groups, resource groups, and creating vibrant climates of inclusiveness, resource groups, can more effectively leverage the resource of diversity to advance our collective capabilities together. Additionally, Michigan Medicine is guided by our mission, vision, values, and strategic priorities. Among those are to promote positive and cohesive culture and improve the value of the care that we deliver. Within these strategic priorities, cultivating belonging and inclusion and fostering a diverse, inclusive, and caring community is explicitly named as outcomes. And then we also know by research is that nationally one of the most important and impactful initiatives in cultivating belonging is the creation of supportive employee resource groups. You've heard ERGs. We are actually calling them resource groups to include the learner voice here at Michigan Medicine. You'll also hear them called BRGs, business resource groups, or diversity councils. But we know that these groups create opportunities for employees to cultivate connections with their colleagues, to find peers of similar identity or experiences, and to provide feedback to leadership to effect a positive change within the organization. It's also noted that these groups provide other benefits to include the development of future leaders, increased employment engagement, and expanded marketplace reach. So Michigan, several of the institutional and individual benefits are listed there, but there are far more. And Michigan Medicine and OHA also recognizes that resource groups benefit for Michigan Medicine and all of our community members. So knowing all that, a little bit of context, I step back a little bit. What is a Michigan Medicine resource group? We are a faculty and staff-led group that helps to celebrate and strengthen diverse, inclusive workplaces. They provide opportunities for innovative feedback to leadership and how to foster inclusion and enhance our climate and culture. Okay, so what's their charge? And I looked at this slide, I was like, gosh, there's a lot of words. Callie, how do you get this down? Just like pictures, images, I don't know. But I actually decided to leave all the words up there because I want you all to know that the resource groups have a lot of work that we're asking them, some heavy lifting and impactful and meaningful work to do, to include the increasing awareness and knowledge regarding issues that influence those who work and learn here at Michigan Medicine. And not only provide perspective for organizational improvement, but they're also going to be asked to offer and submit suggestions to leadership for consideration. They're going to plan and implement community engagement opportunities, so they're gathering socially, pool their knowledge and resources, and then engage in advocacy. We're also going to ask them to provide insights for a community that is anti-racist and inclusive for all persons. And then overall become a champion of DEI work. Our resource groups hopefully will be, as we continue to grow, will be in all levels, in all departments, in all units, and we'll find members throughout all of Michigan Medicine that will be able to be a champion for the DEI work here. So what is the Michigan Medicine, who are they? Again, they are Michigan Medicine resource groups are faculty and staff led. And while they are faculty and staff led, to create continuity year over year, the distinction of resource group, not employee resource group, is intentional to include the learner voice, who are really integral part of our Michigan medicine community, and who also stand to benefit from these vibrant groups. Membership is open to all faculty, staff, learners, and allies, and we consider the faculty, staff, learners, and allies all of our Michigan medicine community members. And an ally is welcome to attend, and an ally is really a person who chooses to align their efforts to improve circumstances for other people. That can mean attending a resource group if you don't necessarily identify with that group, but you want to support them or get to know about their experiences, asking questions, being open-minded, and learning about the issues that are important to others. And then OHA serves as the administrative home for the resource group program, ensuring that the program overall helps to make our workplace culture more inclusive and is aligned with our strategic objectives. So again, who is it? So I gave you a little background of who we are, but after researching best practices and sitting down with peer institutions and partners, we created this structure for the resource groups. They'll have an executive sponsor, they'll have co-chairs for continuity, and 3 different committees: marketing and communications committee, budget and evaluation committee, and outreach and education committee. And before I gave you that example about how we're going to get to the next stage, how we're going to get to affirming, and that's part of why we built in, that example again was employee-led groups conducting assessments, so we have a budget and an evaluation committee, and also getting to that next stage is a hospital launching employee resource groups with executive sponsors, which we included in our structure, and the DEI work is reflected in that operational budget. Again, we don't have the budget, but I am a social worker by trade, so I like to meet people where they're at. I also help them recognize their growth potential, so that's why the budget's up there. Where it's growth potential, and we will have those committees. And I just wanted to touch on the executive sponsor. It's new to the structure for resource groups, and so as mentioned, each resource group will need an executive sponsor. And to be an executive sponsor, one's going to need to be a part of a Michigan Medicine leadership team. So that means deans, associate deans, chairs, chiefs or associate chiefs, or similar roles. And also you must demonstrate the commitment to supporting DEI efforts at Michigan Medicine. So we see this as a really great opportunity for both the executive sponsors and the resource group members for professional development and mentorship opportunities. So if you held one of those roles in the leadership staff and you're interested, please contact me about how we can connect you with some of our resource groups, and so you can learn about the work that they're doing, and we can talk more about the roles and the time commitment for an executive sponsor. So what to expect next? There's a lot going on, but I just want to step back and say this is our first year of this restructure. And so year 1 is growth. With that growth and with a new structure, it takes a lot of work. So we're going to recognize all that work that our resource group leaders and the members are doing. So we're going to announce the structure. Here I am announcing the structure. And feedback integration, we met with the resource group leaders about a month ago. We developed a toolkit and we wanted to hear their thoughts on it. So we sat down for a couple hours and we got some feedback there. But I also just sent them the toolkit a week ago, so they're all red penning it right now, and I don't know what I'm going to get back, but I think it's going to be great, and their feedback's going to be great, and it's going to help make everything better. So we're in that feedback integration phase. November to January, we're going to be looking at marketing campaigns, growth building, membership raising efforts, and also that matching of an executive sponsor with each of the resource groups, and really identifying those leaders, those co-chairs of those resource groups. And then as we move to January and February, we're going to start to meet with those resource groups and think about our short-term and long-term goals, and they're going to have strategy meetings with us at OHA. So if you want to learn more, get involved, hopefully you all had a chance to walk down the concourse and get a flyer. There was a flyer for all of our resource groups. If not, we move them to the table right outside the door. Please take as many as you would want to post in your department or your unit. And you can also go to both our external and intranet site, and you can get connected with each of our resource groups. And you can contact me or OHA to get involved. And then I see I'm getting close on time. So, and then lastly, for anybody in the room or anybody on live stream that are members of the resource group, if you could just stand up, raise your hand so we can all applaud the work that you've done and will do. So. Thank you.
Thank you so much, Callie, for sharing a little bit more about our resource groups, and Ashley as well about our DEI leads. The infrastructure part can be a bit intense in terms of information, but that's really how we get to our next step and how we meet our goals. And so we have really reached the closing of our day, and I asked the question, where do we go from here? So I encouraged you when we started off today to really think about how you could use the information, the opportunities, the initiatives that you learned about throughout today's session to get involved more deeply in our DEI and health equity work at Michigan Medicine. And so I'd like to invite all of you to continue traveling this health equity roadmap with us. There are going to be opportunities to engage more deeply and to get involved, not just in the initiatives you heard today, but to think about how we go from that immersing level to the committing level, from committing to transforming. So I'm really grateful for the things we've heard, and just by way of recap, we heard about culturally appropriate patient care and the work going on with the Health Equity Consult Service. We talked about equitable and inclusive organizational policies, how we look at our culture and what we're doing throughout our different centers in the Anti-Racism Oversight Committee. We talked about how we are engaging and collaborating with our community to be stronger in the work that we do through the Ypsilanti Health Center expansion and the community engagement work led by the Office of Community Health Services. We got a chance to dive deep on what our leadership is doing and how they are setting a vision through our leadership panel, and also, which I really appreciated, thank you so much to our student leaders, to hear about what the Student Diversity Council is doing at that next layer of leadership, because those are our faculty members and leaders of tomorrow. And then we talked a little bit, or quite a bit actually, about data, about race, ethnicity, and language, sexual orientation and gender identity, and then what we're doing with the social determinants of health data and how that all works into the employee health record. And then finally, or the electronic health record. And then finally, we talked just recently about systemic and shared accountability, our DEI leads in our resource groups. So I hope you saw kind of that through line develop as we kind of pull together how we're traveling along this roadmap. But again, those are just those current examples, the things that are already happening. But as we all see, there's still work to be done. We know we have work to do, but we also know we haven't fully represented the work occurring. So some of you may have already heard me share about this, but one of the initiatives that OHA is leading as a part of ensuring that we stay true to that principle of alignment over addition is working carefully with our executive sponsors of the Health Equity Roadmap Initiative to create a health equity database where we're mapping our efforts. So through an initial data collection led by Dr. Okiyama M.H.A, we have about 180 records that were submitted for review. And in that first collection, we kind of went back over that data and thought, okay, what are the other pieces of data and information that we would need to make this really user-friendly so that if anyone who was over in ophthalmology wanted to know what was happening with Health Equity Consult Service and they didn't have any other context, would this database be enough to fully inform them about the initiative that they're seeing? And so we identified about 23 pieces of information that would be critical for folks to be able to clearly understand each of these initiatives. And they go from the very simple, like your unique name, your segment or department ID, the title of your project. You would be surprised in our initial data collection as to how many projects did not have a title. And so we are explicit about needing to know what is the title of your project. And so these pieces of information may seem small, but I do want to highlight them because it's important that if you are making a submission to the database, that you include all of these pieces, because this is how we're able to make this really usable for all of us. And then it gets much deeper. And some of these deeper data points, like the sublevers from the roadmap that I shared existed earlier today, they may be data points that you don't know. So these kind of demographical data points in the database are all mandatory fields. Everyone will fill them out, but we'll work with folks once you make a submission to help identify how this aligns to our work along the health equity roadmap. We also will be looking at metrics and how our work in this space is being evaluated. And so in order to make this truly user-friendly, we have built on our intranet page a knowledge page that gives a robust guide to every question. And so we even explain to you what your unique name is and why you might need it, because we want to make sure that no matter what part of the organization you're coming from, if you have an opportunity to share with us what you're working on, everything can be easily explained and understood. So we go through each of those 23 pieces of information and explain in detail what we're collecting. And our hope is that this will give us that first opportunity to begin aligning instead of adding. And we don't expect all of you to make all of those connections. Here's the exciting part for us in OHA. We can't do all or even most or even a small fraction of the volume of the work that is necessary to reduce health disparities in our care, to create a more inclusive culture. That is a responsibility that we all share together. And so what OHA has the opportunity, and really for me it feels like a gift, to have the chance to work to make these connections among us. And so when folks submit to this database, we'll spend the time poring over initiatives, thinking about how they connect, thinking about how they touch each other, and then making connections between groups doing like work, holding focus groups for people who are thinking about pathways work and trying to help students, holding focus groups for people who are working on data projects and may not have known about the at-scale work that is going on in a different area of the academic medical center. So we'll be using that database to make those connections and to make suggestions about how, if there are 10 units already working on this, could just a little additional funding be enough to really make this a system-wide effort? And we're hoping that this database will give us that opportunity, and also the opportunity, I say this lovingly, but hopefully some things we may need to sunset. We may. And so sometimes when we bring a little light to things, you know, as you feel, if someone is filling out the database and they realize, we don't have any metrics. We didn't think about metrics. We're just doing this DEI activity because it's cool. That is awesome, but we need metrics. We're going to always want to measure and evaluate the work we're doing. So as we do things like fill out the database or ask ourselves these questions, we can think about, I either need to build and I need to do more, or I need to ask for support or find a program that's already meeting the need that I'm trying to address so that we can implement it in our unit or department. And so we're really excited to see us move beyond awareness. Today's title of this symposium was chosen very carefully. When I joined Michigan Medicine in 2021, I was deeply impressed by the amount of thoughtfulness and scholarship and information that was available. Almost everything that you could potentially want to learn about anything is at the University of Michigan, which is why we are leaders in BEST. But awareness and just learning and just studying it is so important, but it's not enough. And so we asked the question, I asked even then in 2021, how do we move beyond awareness? How do we move beyond just knowing that it exists and feeling like there's an urgency and a need to change it, to actually begin to make those changes in our spheres of influences, in the places and spaces where we work? And I really think, and I would posit and submit to you today, that the way that we do that is together. So we saw our leaders here on this stage. We saw all of our most senior leaders, with the exception of our dean who is away, really sit here and tell you they have an interest. There are actions happening in research and in patient care and in quality that are focused on how we move towards health equity. But we also have an opportunity when we come together and push and help them go a little bit further, help them go a little bit deeper, provide the challenge and the opportunity to go to the next step, to change our culture and to continue to improve our patient care. And so we are really looking forward to getting to that final lever on our continuum of change, that transformative state, where what we do not just impacts us, because it starts at home. So first, we want to have a culture that is safe and inclusive for our employees, faculty, and staff. And then we want to expand that experience in our patient care. And then we want to see how that reflects in our community. And that's where transformation and structural change comes in. It is not easy. And we're not telling you that this is an easy trip to take, but we are committed and excited about partnering over these next 5 years to begin making some structural change. It will take focus, it will take intensity, and it will take all of us to reach our shared goals. And so we are really, really, really grateful for each of you for staying in the room. I would say give yourselves a round of applause, please. Little bit louder. Because the energy today, I think our team as OHA as a whole, we couldn't have asked for more. Your excitement, your engagement, the questions you asked, the hard work we know you've put in. What brought you here today is what makes this work possible to do. So I'm so grateful for each of you just for showing up today, and I'm excited to see you continue to show up in this work as we move forward on this journey of alignment over addition. And with that, I will bring our Associate Vice President and Associate Dean for Health Equity and Inclusion, who is my boss and he's just really an amazing advocate and supporter for this work. And so I'm so grateful for Dr. Brown. And so Dr. Brown, if you would just come and bring some closing remarks, we would be grateful.
Thank you so much. Kristen is truly amazing. Let's give her a round of applause. She deserves it. So wasn't it this an amazing and informative day? Yes. Yeah, I heard so many of you talk during lunch. And the energy was really high. And I know it's a long day and that, most of you stayed here, so I'm so grateful for that. I think one of the reasons why the energy is so high is because as an academic medical center, our true north is consistent, that we're here for the patients and we're here for health equity and to give the best outcomes for the patients. We're different, as was stated earlier, than all the other schools and colleges at Michigan, and that brings us all together. And I'm so proud that we're seeing so many diverse individuals, not just diverse in race and ethnicity and gender, but in job and job classification, because we're all committed to the patient work and the healthcare equity, so thank you. I'd also like to thank all the presenters and the panelists and the speakers today. They did an amazing job, and I want to especially thank Ashley Wilson, so please stand up. Get your thanks. Yes. And Ashley alluded to earlier that it was also all of OHA who helped out, and they all chipped in. So all the OHA people, please stand up, including Ashley and Kristen. Everyone stand up. And if you're standing already, raise your hand so everyone knows who you are. Sue, raise your hand. There you go. All of them an amazing team, and they brought us all here this today. So today was the first time we shared on a grand scale a lot of our health equity work and opportunities. Most of this work started over the past 5 years or intensified over the past 5 years. So during our DEI 1.0 to 2.0. I hope that everyone has a greater sense of awareness of the work that's going on, and now it's up to you and all of us to go beyond that awareness, okay? So my questions to you, I know Kristen had a lot of questions as well. How will you get involved? Who will you partner with? How will you align your work with DEI, health equity, anti-racism? How will you be a disruptor for equity? And as the theme, and I love the picture right here in front of me and on our tags and everything, I love a metaphor and an analogy, so I'm going to take this a long way. So as this theme stated, building structures for equity. Let's remember that some things are built from the ground, and some of them we need to do. Some of the things, like Kristen said, we need to sunset, and so there is no bulldozer on here, but sometimes we need to break things down. And some things we require bulldozing and rebuilding. And I think there's lots of things, lots of structures in medicine that we need to break down and rebuild completely because they're not equitable for a lot of us. And some of them might just require an addition or a fresh coat of paint or to do an addition on the house or a restructuring. So my charge to all of you is that we need equity builders. And so my charge is for you to all, and I love alliteration too, you to all be a builder beyond awareness for DEI and health equity. Thank you.
So the last announcement of the day, we have these lovely centerpieces on the table. So if you look on your chair on the right back leg at your table, one person will have a ribbon on the leg of their chair. And if you have the ribbon, the centerpiece is yours. Please take the lovely flowers home, the entire centerpiece. And thank you all. Have a great rest of your day. Thank you, everyone.